Well, hello, everyone. Good afternoon, good evening, and welcome to the International Myeloma Foundation's Virtual Myeloma Community Workshop. Today, we're going to hear more about relapse and refractory myeloma, and we have wonderful experts on the call with us today. We have Dr. Yi Lin and Dr. Lip and Dr. Liu and Dr. McHale and myself, and we are all going to be engaged with you and taking questions and learning more so you can have better conversations with your own healthcare team. And today we thank our sponsors, and that is AbbVie and Amgen, GSK, Johnson & Johnson, Karyopharm Therapeutics, Pfizer, Sanofi, and Takeda. We are always grateful for their educational support and bringing you these wonderful programs. The agenda for today, you can see, is quite robust. We have built-in breaks for you so you can take not only a brain break, but walk away, stretch, get a bite to eat. So you can see we start off with myeloma 202. I think it's really interesting because we did 101 earlier this year, right, Dr. Joe? And now we're moving on to 202, which is really all about relapse, refractory, response, and progression. What does it all mean? And how do we have better conversations so we can do well and live well with myeloma? And then we'll hear more about the treatment landscape in relapsed myeloma. Thankfully, today, with all the research that we have available, there are many options for you to consider and have conversations on. And then we'll have a break, and you can see the rest of the schedule with CAR-T. And then we're also going to talk about quality of life and side effect management with the seasons of myeloma. We'll have all of our panelists today talking about clinical trials, and we'll have lots of time for open Q&A, and let's just keep moving forward to get this started. I know you're all excited to get engaged. So right now, this slide is showing you a little bit about how do you ask questions to the hosts and panelists. So right here is how you do it, and you click right in here, type your question in. And I don't know, Dr. Joe, I think we've set records in the past for how many hundreds of questions you can get to with the panelists. So while we try and do our best, we may not get to every single one of them, but many of you may know we have the IMF info line that is always available to you, and that's 1-800-452-2873. You can call and ask them additional questions, or submit your questions to the IMF. And Dr. Joe, who knows, maybe you'll do a Facebook Live or Myeloma Made Simple episode on some of these questions as well. And feedback survey. If you've been on any of our programs in the past, you know the IMF seriously takes your information to improve every single one of our programs. If we're not listening to you, then we're not doing the best for you. So please make sure that you fill out this survey. It's really short, but really important. Also, after this program, as all IMF programs, we do record them, and the replay will be available in the future. If you look at this slide, and you can see the gray box where it says publications and videos, if you click on there, and then you slide over to where it says IMF videos, and today it is a regional community workshop, you could find it there, or you could just find it right under that IMF videos link. So you can go back, replay it, listen to it again, take your good notes, ask your good questions. So here we go. It's my privilege to turn it over to Dr. Joseph McHale.
Thanks so much, Robin. You're most kind as always. And you've already answered one of the questions that have magically been submitted so quickly, which is where can you find recordings on the IMF website? So very well done. Amazing. So thanks everybody for joining us. As Robin mentioned, we are doing 3 virtual community workshops this year. We did one on frontline therapy. This one's on relapse. And then the last one, we're going to talk about sort of hot and controversial topics. And you'll hear more about that and see it posted in social media when that comes up in November. But we really felt it was important to have a whole session dedicated on relapsed myeloma, which is why we're calling it Myeloma 202. And so what am I going to do? I'm really, as I often say, I am just the appetizer. The real meal is coming when Dr. Leip talks to us more about all the options we have in relapse, when Dr. Lin talks to us about CAR-T, when Becca Liu talks to us about how we make sure our lives stay well throughout all of these kinds of treatments that we're getting. So I'm really just kind of warming up the crowd here. I'm just the first act, the real acts are soon to come. But what do I want to do in the next 15 minutes or so is address the question of why do actually relapses occur? This is a very common question we receive repeatedly, the IMF. So I wanted to take a few minutes to discuss that. And then really the heart of my talk are just 10 important principles to remember as we think about treating myeloma. I mean, I love this. When I started in myeloma and just about every other panel member here was still in utero, I didn't have a lot of choice. We basically had one or two drugs for myeloma. So there were no principles for selecting therapy. You just had to choose one of two things. Now that we have so many choices that you're going to hear so much about, we want to give guidance to you and your team about how we make that decision. And in that, I really want to, there's one thing that I would like you to walk away from today is not just knowledge about CAR-T and all the new treatments and all the things, but is reminding you as a patient, as a care partner, that you have a voice in this, that your part of the decision-making is critical. It's not that you're just an add-on. You are central to that decision. And then that way we can really make sure you best understand what options are yours so that you can make that decision intelligently. So why do we see this, that myeloma almost always relapses? Well, you may have seen a picture kind of like this before, and it just reminds us that before anyone gets myeloma, they have what we call the pre-myeloma conditions, MGUS, or monoclonal gammopathy of undetermined significance, smoldering myeloma, where we typically don't treat, although sometimes we may treat a high-risk smoldering myeloma. And then eventually the disease really takes off and it gets treated. When it gets treated, as you can see from the red line, it goes back down again. We get some kind of remission. And remember, remission does not equal cure. Remission is really a word that talks to us about the fact that we've reduced the burden of disease. It's like a response. We brought it down a degree. We'll talk about that degree of going down in the near future when we talk about minimal residual disease, or MRD. But then sadly, the disease does come back. Typically, and unfortunately, when it comes back, it tends to be more difficult to control, and it's harder to keep it under control over time. But why does that happen? Well, we really speculate for several reasons, but I'm just going to focus on two. Number one is when we first treat it, even though we sometimes get the disease way down, and you may even hear your doctor say, oh, you got to MRD negativity, or minimal residual disease negativity, meaning we can't detect any of your disease. With all due respect to us as a medical community, it's not really 100% completely negative. We do think that there are a few pockets, a few places in the body where some of those myeloma cells hide out, and eventually they have the opportunity to grow again. The other thing that happens in myeloma is the immune system. You know, it's a miracle, by the way, that not all of us on the planet have cancer. A lot of our prevention of cancer has to do with the way our immune system, whenever it sees a cell going in the wrong direction, as it were, it pulls it back and says, no, don't become cancerous. And sometimes when our immune systems are weakened for various reasons, we don't have that same control over our cells. And in particular, the plasma cell, which is the cancerous cell of myeloma, of course, which you learned in Myeloma 101, when you came to the previous virtual workshop, that plasma cell then starts to grow out of control. And that's one of the reasons why we see myeloma come back again. Now, I know this is a scary looking slide, and it's got lots of letters and numbers and pictures on it, but it's still one of my favorite slides. So I hesitate to ever show this, but let me really keep this simple. I want you to look at the second half of the slide, and you see there are 3 columns, and they all start with the letter E. And that's what we want to think about today. what is going on with the immune system in cancer? Well, the immune system is constantly trying to, first E, eliminate cancer. So believe it or not, we have cells in our body that at various points in the day are trying to wake up and become cancerous. But your immune system, kind of like a really good teacher that sees the student looking out the window when they should be listening to make sure that they're ready for the test, will look and say, hey there, Bria, you listen, listen there, Billy, don't get off track. And it eliminates that tendency towards cancer. But sometimes it can't completely eliminate it. And so the second E kicks in, what we call equilibrium, where, believe it or not, there are times we have tiny amounts of cancer in our body, but the immune system keeps it under control. This is what happens with MGUS. This is what happens with smoldering myeloma, where there's a little bit of cancer there, but not enough that we need to do anything about it, and the immune system keeps it under control. But sadly, at some point, there's the third E, what we call escape, where the disease can no longer be controlled, and it just breaks out and gets out of control. That's the simplified way of thinking how our immune system contains and eliminates cancer. So in myeloma, unfortunately, what happens when we can't fully eliminate the myeloma, we may go through a period of time where there's some equilibrium, but eventually it escapes and the disease comes back. All right, enough of the fancy smashy pictures. What choices do we have for myeloma? Well, this looks like an alphabet soup, doesn't it? But it is remarkable how many new therapies we have in multiple myeloma. So many of these drugs you're going to hear about over the next couple of hours. I'm not even going to read them all, but just to give you a sense of all the kinds of choices that we have on the left. And then many of them get used in combination. So it even adds to the number of choices we have as we combine a lot of these treatments together. All right, well, I'm going to just spend the next few minutes going over these top 10 key principles of treatment selection that I think will help us as we go forward. And so number one, change the current mechanism of action. So sadly, when the disease wakes up, a lot of times patients are on a current therapy. Typically, let's say they're on maintenance Revlimid or on maintenance Darzalex and Revlimid. What's happening when that disease wakes up while they're on that drug, it's broken through that drug. So typically we don't just say, oh, let's just add something else to it. That may very, very rarely happen in unique circumstances, but usually we say, look, the myeloma is so smart, it figured out this drug or this combination of drugs. We need to go to a different way of treating it. So typically, as we make a decision, one of the first things we do is say, okay, let's change the mechanism of action. Let's go to something that the current disease is not breaking through. And when we think about those drugs, again, it is ridiculous, isn't it? How many different classes of drugs we have that work in a different mechanism of action. We often talk about the IMiDs and the proteasome inhibitors at the top here, as well as regular chemotherapy, steroids, everybody's favorite, DEX that we'll talk about later, monoclonal antibodies and XPO1 inhibitors. So typically, if someone's broken through one of these classes, we either get a different drug from that class or change the class entirely. But we also have now more classes that you're going to hear from my colleagues here in a minute, particularly the CAR T-cell therapy and the bispecific antibodies. Principle number two, don't save the best for last. We don't want to wait until the disease relapses multiple times and becomes really aggressive. And I know that both Dr. Leip and Lynn will talk a little bit about how we often use CAR T-cell therapy earlier now than we used to, because we don't want to save the very best, as it were, for last. We want to give people the best chance to respond in the short term, because what we do in the short term is going to have a long-term effect. If something works after 5 or 6 lines of therapy, it's going to work even better in earlier line therapy. Number three, we typically use CAR T-cell therapy, bispecific antibodies, or triplets at relapse. That's not always the case. There can be some exceptions to the rule, but usually it's one of these 3 approaches. And you're going to hear much more about it as we go over the course of the day today. There may be some situations we may use a doublet or sometimes even a single drug, but for most people, it's either a combination or one of these new approaches with CAR T-cell therapy or bispecifics. Now, I mentioned that principle number 4, 5, and 6 had to do with looking at patient factors, disease factors, and treatment factors. What does that mean? Well, when I look at a patient, I was teaching the medical student in clinic with me today that we don't treat myeloma, we treat people. And it's so important to look at the whole of the person. And this has to do with what are their preferences? What are their social factors? What other diseases might they have, like diabetes or heart disease or kidney damage? Those things might influence one choice over another. But then we also look at the disease. One of the things we understand about myeloma is it's hugely variable. Some people relapse 6 months after their first treatment. Some people relapse 6 years after their first treatment. Some people even more than that. So we have to look, is it happening quickly? Is it happening slowly? I already saw one of the questions that came in about biochemical relapse that we can talk a little bit later about. But in short, this is where we start to see the numbers go up, but the patient feels well. And we've been moving as a field more and more to intervene quickly. Why wait until someone breaks a bone? Why wait until something is damaged? We tend to intervene sooner. We know that myeloma can be divided into high risk and standard risk disease. And so that risk status becomes very important. And then lastly, the treatment factors themselves. What side effects do we expect from them? How many times do they have to come to clinic? Some people might say, look, I don't want to take a drug that I have to come in twice a week for. It's hard for me. I live 3 hours away. That may push them to choose a different treatment. Number 7 is depth of response matters. I talked already a little bit about this, so I won't go into much more about MRD negativity, but this is this concept where it's one thing for the disease to drop a bit, it's another thing to get it down. Now, we can't seek MRD negativity in absolutely every patient. We know some patients won't get MRD negative, but will still do very well. But we know in general, as this picture kind of shows you, the deeper you get, the longer you'll stay there before the disease wakes up again. All right, last few principles. By the way, just to show you, when we talk about depth of response, MRD is the deepest level of response, but we have other levels when people get into a complete remission or a very good partial remission when it's dropped by 90%, or even just a partial remission over 50% can sometimes be sufficient. So when we come here to number 8, which is sequencing is important, but not fully known. What does that mean? I'm sure if I talked to Yi and Bria and Becca and said to them, all right, Dr. Joe is going to host a myeloma meeting next month. How are we going to get people to come to this meeting? Why don't we call the meeting the perfect sequencing in multiple myeloma? Everybody wants to know the right sequence, but the reality is we don't really know what the best sequence is. When you have all this choice now, what is it better to go for versus other? We don't really know, but we do know that it has to be matched to that person. And there's a couple of things that we've learned a little bit more over the last few years, that if someone is eligible for a CAR T, we tend to prefer going to CAR T before a bispecific, just by nature of the way the treatments work that we're going to hear about shortly. Also, that all therapies really can be sequenced in just about any order. We can go the opposite way as long as we give T cells a little bit of a rest. So both for CAR T cell therapy and bispecific antibiotics antibodies, we engage the body's own T cells, those natural soldier cells that we call T cells. And we're learning more and more that we need to maybe give our T cells a bit of a break. But I'm going to leave this out there for a little while because I know that both Dr. Leip and Lynn will cover this a little bit, and we'll come back to this more in the questions. Principle number 9, always include a quality of life discussion. As I noted, we don't treat myeloma, we treat people. And so it is really important to look, and I know that Becca's going to share a little bit more with us on this, and making sure that you realize that you're not just a collection of plasma cells, like you're a person, you're a human, and your quality of life and how it affects your quality of life, short-term and long-term, is very, very important. And lastly, and arguably most importantly of all the principles that I've just shared, is to ensure that we use the shared decision-making model. What is that? That just basically is approach. You can see what's called here the share approach. It's telling doctors here, for example, seek your patient's participation, help your patient explore and compare treatment options, assess your patient's values and preferences, reach a decision with your patient, and evaluate your patient's decision. That's a relatively 5-step complex way of saying that patients need to understand what the options are, pros and cons, and they need to apply that to their own goals. So instead of me saying, I'm your doctor, I think you should get this, you're going to take it, you're going to enjoy it, is very different than saying, look, I think in this context, we have these 4 options. Let's walk through them. Let's see which one matches most of what would be best for you, and we make the decision together. That's what shared decision-making is. Lastly, I always put a plug in for what I call the expert opinion. Some people call it the second opinion. I'm sometimes hesitant to call it second because it almost makes it sound like the first one was wrong, but it's often not wrong. But you do have the opportunity more often than not to get a second or expert opinion, an opportunity where you can speak to someone who spends more of their time, like all of us on this call here tonight, in multiple myeloma. Myeloma is only about 2% of all cancers. So it's hard for everyone to be an expert in myeloma, and it's pretty complicated. That's not to demean your doctor in any way, shape, or form. But often that second opinion or expert opinion comes through your doctor. They call. I get phone calls. I got 2 calls today from local doctors who just said, "Oh, Dr. Joe, I have this case. Can you give me some advice?" We just want that open line of communication between the patient, their provider, and a myeloma expert in whichever way it happens. And pretty much my last slide here, it is overwhelming how many new drugs keep getting added to the list and how many are coming. We're going to end our discussion today before the Q&A with everybody together on clinical trials. Without clinical trials, we wouldn't be where we are today. And it just amazes me how many more treatments are being evaluated in clinical trial. Of course, you can always reach out to us. Robin already mentioned from the very start that we have all sorts of resources available for people who call in or email in. We actually have a AI chatbot now named Milo. So if you go to myeloma.org, Milo will appear in the corner, and you can ask Milo anything as well. Especially if you're on dexamethasone and it's up at 2 o'clock in the morning and you can't sleep and you want to ask a question, always feel free to ask Milo questions too, because we've built Milo within the myeloma website so that it's only going to answer appropriately through what information we have. On the subject of information we have booklets, tip cards. We get, there's a free quarterly newsletter that's just about to go out, the summer edition. Every week we have updates when what we call the Myeloma Minute. And basically for every single drug that we have in myeloma, we have a whole booklet. So you can download these virtually and receive them electronically. You can order them to get them in print. We want to provide as much education as possible because that will empower you to go through all the decision-making that we're going to be discussing today. So with that, I am going to thank you for your kind attention. Thankfully, we're right on time, so I'm going to turn it to not only a colleague, but a dear friend, someone who I respect immensely and love dearly. Dr. Bria Leip is at the University of Rochester in New York State, and she has led a myeloma program there. She's done basic science research. She runs clinical trials. She takes care of patients. She takes care of her family. She's particularly good at camping. I get to see lots of camping pictures with her family. Bria is really remarkable. And Bria, we've given you the tough task of diving in a little bit deeper to that huge outlay of options that I proposed earlier. So I'll turn it to you to talk to us about treating relapsed myeloma. Thanks so much, Bria.
Thank you so much for a very kind introduction, and I'm really happy to be here. So, as Joe said, we spend a lot of our time doing all sorts of things related to myeloma, but I think what motivates all of us is the people listening here and how we can make it better for our patients and give them the information they need to make the best decisions for themselves. So I'm going to focus today on the treatment landscape for relapsed multiple myeloma. So I'm going to first go through and expand on some of what Joe has already said, how we define relapsed multiple myeloma, what are some of the advances that we've made in the treatment of multiple myeloma, and then take a little bit more of a deep dive into the drug classes, the arsenal, so to speak, for how we treat this disease, looking at those treatment options and how to interpret some of the information that is available to all of us. And then how do we pick amongst all of these different options that we have? What should be our goal of therapy, not just from a disease perspective, but from our patient perspective and in terms of quality of life and all of the things that you've already heard about? And what are some guiding principles that we can rely upon? And then as we look at different lines of relapse, earlier relapse versus later relapse, we're going to get into some of the newer therapies, the bispecifics, and some of the BCMA-directed therapies, some of our emerging therapies. So when we talk about relapse disease, there are definitions for what it means to relapse, and those can be biochemical, definitions, meaning that we've had a change in our blood values, but patients are not having symptoms yet of multiple myeloma. We just see in their blood that things are growing or things are changing. And then there can be a sort of a clinical relapse, in which case patients are having symptoms from their myeloma, oftentimes similar to the way they presented in terms of either bone damage or new masses, or their hemoglobin starts dropping and they're becoming more anemic, or their kidney function starts to deteriorate. And that's what we call relapse multiple myeloma. Now, one of the questions that I also saw was about refractory multiple myeloma. And typically when we talk about relapse, it means that a disease had been well controlled and is now growing, versus refractory, meaning that maybe the disease hasn't necessarily been growing significantly, but it has never really achieved the level of control that we were hoping to accomplish. And so this is similar to the slide that you've already seen. And just a couple of things to point out here is that this was a standard slide that we used to show in terms of what myeloma remissions can look like. So we have active multiple myeloma, and then typically we always thought that our first remission was our deepest remission and our longest remission and the best remission we could accomplish. And then over time, the disease relapses, and our subsequent remissions tend to be either less long or less deep, and they probably go hand in hand. And so that's been the historical truth in multiple myeloma. And that's something that we're seeing we can actually upend a little bit, because some of our therapies now are so much better that we're able to get deep responses even in later relapses. But our goal is still to get these deep remissions. So we know that we're making headway because patients with multiple myeloma are living longer now than they've ever lived before. And that's because of the introductions in our new therapies. And so this, you can find this on the SEER database, but also in trials that we've established, people are living longer when they have multiple myeloma. And one of the things I always tell my patients is that all of the new drugs that you'll hear about and all of the things that are coming out that you're going to hear about, we haven't had those for the amount of time that patients are currently alive. And so the true natural history of myeloma has fundamentally changed. And that means that people will continue to live longer and longer. So this is another slide that I always like to show because it's changed so much. And this is just looking at all of the different therapies that we have. And you can see that the initial part of our timeline was really spread out. From 1995 to 2019, we didn't have a lot of new medications in multiple myeloma. But the second half of our slide has all been in the last 6 years. We're seeing all these new drugs that are coming out. So the pace of change and development in multiple myeloma has changed significantly and continues to do so. So as we start to look at the classes of medications that we use in multiple myeloma, one of the classic drug therapy classes that we use are the IMiDs. These are one of our oldest options for the treatment of multiple myeloma. And these are typically oral pills. They include things like thalidomide, lenalidomide, pomalidomide, and then the cereblon inhibitors are not technically IMiDs, but similar in their function. And so I included them here. These are all oral drugs. Commonly, these things can cause a risk for venous thromboembolism, rash. There's always a warning in a REMS program because they're teratogenic, or meaning that they can cause birth defects if they are exposed, pregnant people are exposed to these drugs. And then it can lower your blood counts. And then sort of how these drugs work, I think, is one of the interesting things. And so a lot of our drugs in multiple myeloma capitalize on the fact that cancer cells are programmed to grow. So as Joe was saying, our immune system is designed to help control these things and keep them in check. And when they are escaping these immune mechanisms, these cells like to grow. And there are things that a cell needs to grow. And one of that is a really robust production factory. We need to be able to make the protein, the cancer cells need to make these proteins that help the cell survive. And so a lot of our drugs capitalize on that. And when you interfere with the production mechanisms that are required to keep these cancer cells alive and growing, they start to die. And that's part of what happens with IMiDs. And it works in multiple different ways. But one of the things it does is it really interferes with the cell's ability to make the proteins it needs and get those proteins out into the environment and allowing these cancer cells to survive. So if they can't grow, they can't hurt us. So proteasome inhibitors is another one of our major classes of drugs in multiple myeloma. And the three main drugs in this category are bortezomib, carfilzomib, and ixazomib. So bortezomib is most often currently administered subcutaneously. We used to give it IV back in the day. Carfilzomib is IV, and then ixazomib is an oral proteasome inhibitor. These drugs, so neuropathy is one of the things we see with some of the proteasome inhibitors, particularly with bortezomib. Cardiac toxicity can be a signal for carfilzomib. And then all of these drugs can cause some GI upset, which is, in my experience, generally pretty mild, usually constipation or diarrhea. And there can be some viral reactivation or risk of shingles. So we often prophylax patients against shingles when they are on proteasome inhibitors. And so similarly to the IMiDs and how they interfere with the cell's ability to make proteins, proteasome inhibitors do the same thing. So what it does is it increases the proteasome is a mechanism inside of our cell to deal with all of these proteins that are made by a cell, and sort of like they kind of work like the garbage dump in terms of keeping the cell clean and healthy. And so if we interfere with the cell's ability to clean itself and keep itself getting rid of all these proteins that it needs, and all of these kind of junky proteins build up, we see that plasma cells die. So the next class of drug that I was going to spend some time on are the monoclonal antibodies. So these are a newer class of drugs. And so these drugs work a little bit differently in that they specifically bind proteins. So there are two main classes of monoclonal antibodies that we have currently in multiple myeloma. Others are in development. But right now, the ones that we have are anti-CD38 driven with daratumumab and isatuximab. Daratumumab can be given IV or subcutaneously as an injection. Isatuximab is given IV currently, although that is likely to change soon. Elotuzumab is looking at a different target. It's a SLAMF7 monoclonal antibody. So all of these classes of monoclonal antibodies cause a risk of an allergic reaction type when we get it the first time. So usually people take some medications ahead of time to prevent these allergic type reactions, because really what we're asking these drugs to do, or what these drugs are helping us to do, is help our immune system to help destroy our plasma cells. And so anytime you activate the immune system, as we'll hear more about, there are risks with that. So there are risk of these reactions that are really only limited to the first 1 or 2 times that you get them. There's a risk of infection because of what we're targeting, low blood counts. And these drugs as a class can interfere with our ability to type your blood. And the reason for that is because these are antibodies. And when we're typing blood, we're looking for antibodies. So when you have them, this is what we see. And so the way that these drugs work is they bind to proteins that are specifically expressed on plasma cells and are more highly expressed on these abnormal plasma cells like CD38. And when we bind them, these antibodies flag our immune system as, hey, something's going on here, and helps our immune system to kill these cells, these abnormal plasma cells. There are a few other classes of drugs that we see in multiple myeloma. Selinexor is one of our newer drugs. That's a SINE inhibitor. So that's also another drug that is involved in the protein mechanisms within the cell and interfering with the cell's ability to make the proteins that it needs. And when you can't do that, these cells die. So basically you're blocking some of the cells that get out they're blocking certain types of proteins that tell our body to behave around cancer cells and allow them to survive and exist. And if we prevent those signals from getting out, then the rest of our immune system is better able to respond. Selinexor in particular can cause some nausea and anorexia that can be challenging, but can also be addressed with dosing adjustments. And we sometimes see some low blood counts as well. Venetoclax is a drug that's approved in other types of cancers, but in multiple myeloma, we know that it's helpful in certain types of multiple myeloma where patients express translocations 11-14. And the reason for that is because these patients with translocations of 11-14, which is probably around 10% of our patient population, when we see that, we know that they're more likely to be overexpressors of a certain protein that helps cancer cells to survive. And when people express this highly and we interfere with that, these cells die. So venetoclax it's a pill like selinexor can be also very effective for patients with translocations 11-14. Cytoxan is an older drug, it's an alkylator, and basically it just interferes with the drug's a cell's ability to grow. It's less specific, so it's an older drug, a more classic chemotherapy. So this is from this is a guideline for options for treating relapsed multiple myeloma in 1 to 3 prior lines. And I only bring this up because, as you've already seen, there are a lot of different options. And so even when we as physicians are looking like, what am I supposed to do here? This is what we see. So we need a more nuanced approach than this to help decide what treatments are actually right for our patients. The nice thing about having all these different options is that we really can tailor our therapies to the person in front of us. We have a laundry list of options, and so helping us find the best options to help you is what our goal is and what this is all about. And so when we take all of that together with our patients, we're looking at our disease characteristics and our patient characteristics. And I think of it like a big giant puzzle. And so how do I take all of the pieces in front of me, your disease, your social history, your personal concerns and considerations? How do I take all of that and fit these pieces together to create a uniform approach that's going to help you? So when we think about the patient, some of the things we've already discussed is, really what are the toxicities that people have that they've already had? When you've already had some neuropathy, we want to make sure that we're not giving you another drug that can make that worse. If you have some cardiac disease, that's something else that we need to think about. What is your preference for the goals of your life? What are you hoping to accomplish? And then what does the support system look like? How far away do you live? In Rochester, we have a lot of patients that drive hours and hours to see us, and how manageable that is for an individual can be very unique. And there are also limitations that patients have. I have lots of patients who travel a lot. And so if they needed to come and be tied to a cancer center for infusions or injections, that really limits what they're hoping to do with their life. And so they really like oral options. So all of these things come into play as we're trying to figure out what the best treatment option is for the person in front of us. But then ultimately, when we put all of that together, we want to know about their disease itself. What therapies have they been on and already progressed on? Like Joe was saying, we try to switch classes. How long did those prior therapies last? Because if they lasted for a short period of time or a long period of time, that can tell us information about the disease and how aggressive or refractory your disease has become. What doses did you get? If you're on very low doses of a drug, maybe we can adjust that to get some activity out of those drugs that you've already seen. How much time has been between the last therapy and this one? Because if it's been a long time since you've seen a certain class of a drug, it might be time to re-challenge with that class of a drug. And then what is the pace of the disease relapse? Is it a biochemical relapse? Is it rapid? Is it a very slow? Are we seeing a new emergence of extramedullary disease, which is when tumors start to grow outside of the bones? Are we seeing new chromosomal mutations? Or do we have a target like the translocation 1114 that I already talked about? But again, the goal of our therapy here is to achieve minimal residual disease. What we know is that the deeper the response, the less myeloma you have, the better you do. And we can detect this in novel mechanisms. So what it means to be MR negative, minimal residual disease negative today is different than what it meant 10 years ago when I was first starting out. And that's because we have these newer mechanisms. So sometimes I get questions about this. And so one of them is the next generation flow. And I think of this as sort of each cell in our body has sort of like a zip code that's attached to it. And that zip code consists of different proteins that can help us recognize whether this is a cancer cell, a cancerous plasma cell, a healthy plasma cell, or a skin cell. So if we could read the zip code on cells, that's what I think of like next generation flow. It's really the ability to read the proteins expressed on our cancer cells. Next generation sequencing is the other real mechanism that we have to detect very low levels of disease. So specific that we can look in your bone marrow and see that 1 in a million cells is not an abnormal cancer cell. And so we do this typically historically with bone marrow biopsies, but this is where new technology is emerging such that we might be able to even find it in your peripheral blood. And so those tests are also being worked on. And this is a little bit different from flow. We're not really looking for the address. What we're looking for is a gene signature. So we know when you're first diagnosed that there are unique sequences of your DNA in your cancer cells, and we can identify those. And so then later on, when we're looking for how many how much disease you still have. What we have to do is just look for that sequence. So we don't necessarily need to know what cell it's coming from or find that individual cell. We're looking more specifically for a gene sequence. And when we have the right sequence, we know that that means that it came from the cell that caused your cancer. And so it's a sequencing driven assay. And so when we talk about achieving minimal residual disease, this is something that's evolved significantly in multiple myeloma and is now the target of a lot of our clinical trials. And so I wanted to take a minute to show us how important this is, but also to help us understand what we see when we talk about some of these progression-free survivals. And so what you see here in the screen is a graph that you might have seen a lot of times in trials for all sorts of different therapies, including cancer and multiple myeloma trials. And what it tells us is how likely a patient's disease is to stay in remission at a given time. So you can see here at the very top line is a maroon line, and that those patients do really well because at 48 months, over about 75% of patients are still without having disease relapse. So, and compare that to the very bottom line, where at 24 months, now only 25% of patients have not relapsed. So that's how we look at this. And I think that's important and helpful because that's something that we see in a lot of our trials. And so why I bring this up is because we've accepted for a while that in the newly diagnosed setting, achieving those deep responses like we've seen on those graphs of how myeloma absolves is very important. But we know now that it's also important in relapse disease. And so of all these fancy lines here, I'm pointing out here the two lines that represent patients with relapsed refractory myeloma. And so you can see here the dark green line, those represents patients with relapsed refractory multiple myeloma who have achieved MRD negativity. So when you achieve MRD negativity, that very, very deep response, whether you're looking at 1 in 100,000 or 1 in a million cells, you can see that those patients do better. So at 36 months, 75% of patients still have not had return of their disease versus patients who do not achieve MRD negativity, meaning that they still have some detectable disease. Those patients tend to do worse. And that's what's seen in this bottom curve here. And at that same 36-month mark, we're looking at 23% of patients who haven't progressed. So that's why we look at MRD status as a surrogate for response and why it matters, why it's important, and why we check it. So again, this at the bottom, this is another graph that you often see, and it just shows us when you have relapsed refractory multiple myeloma, being MRD negative still matters. And so that suggests to us that this is still an important goal for us to achieving in our patients with relapsed. So then we again alluded to these different types of relapses. There's a biochemical relapse, which can be loss of MRD negativity. So we can see this in the blood, but sometimes we need very deep molecular testing like the bone marrow biopsies to see if someone who's MRD negative is no longer MRD negative. That's a type of a relapse versus a symptomatic relapse when patients have one of the criteria for multiple myeloma, whether it's kidney disease or bone disease or some manifestation of their disease. And so one of the novel areas of investigation in multiple myeloma is what to do with these different types of relapse. And so there are different options when we have these different types of relapse. So one of the real questions that we have now is we have this technology to detect very low levels of disease. What do we do with it? And so clinical trials are starting to ask that question. So the Perseus trial and the Remnant trial are two trials that looked at in patients with newly diagnosed multiple myeloma. They get their induction regimens, they get their transplants, and then they go on to their maintenance therapy. But the interesting thing about these two trials is that patients who get their maintenance therapy in the Perseus trial, when they're MRD negative for a period of time, they're actually able to stop some drugs. But then when that MRD negativity returns, so when they've lost MRD negative status, so a biochemical relapse, if you will, they actually add a drug back. And the question here is, do we do better by treating these very low level relapses, or should we wait? And that's what these trials are essentially asking. The Remnant trial is doing something very similarly. Do we treat when we first see a biochemical relapse, or do we treat when we see actual symptomatic disease return? And so these two trials are still ongoing and will give us information. But the Predator trial asks a very similar question, and we have some initial results from this trial. And so this was again a trial that looked at patients who've achieved MRD negativity and then lost it. So when you lose that MRD negative status, meaning that you still have very low level disease, you would have no idea you're not symptomatic. It's something that we see because we did a bone marrow biopsy or deep testing. Is it better to treat it with something like daratumumab or to observe? And in this trial, those curves that I mentioned here, we see is that those patients who were randomized when their MRD negative status was lost, when they got treated at that level, those patients ended up doing better overall than the patients who weren't intervened upon and who are allowed to just go ahead and relapse to a clinical relapse. And not only did those patients who got the daratumumab end up having longer before they had a symptomatic relapse, but they also were able to re-achieve MRD negativity in a large portion of those patients. So this is some of the initial data that we're starting to see about how we manage some of those biochemical relapses. And I bring that up and spent some time on it because it's one of the newer frontiers that we have in myeloma. When we're looking more at the traditional, what it meant to have had disease relapse, a lot of the trials that we have done historically in multiple myeloma to even be eligible, biochemical relapses didn't count. You have to have a certain level of measurable disease to even be eligible for a trial to ask if it was better to do drug combination A or drug combination B. So in the setting of those types of trials, we've done a whole bunch of trials because historically we used to say that we can use 2 drugs to treat relapsed myeloma, and that's good. So this is getting back to Joe's idea that we don't really need to or want to save our best for last. So just because I have 2 drugs and I have these new drugs, maybe 3 is better than 2. And that's what the next pioneer field in multiple myeloma started to look at. So historically we did 2 drugs. Now we've got better drugs. What happens when we use them all together? Because it's not just that we have more drugs. We have more drugs that are tolerable over a long period of time. So I can add more drugs in combination, have the opportunity to treat your disease better, but not make you sicker. And so that's where the new pioneer, years ago now, allowed us to come up with this idea that triplets are better than doublets. So pretty much any 3 drugs that you use in the relapse setting, and that will change as we add more, but at least in the relapse setting, 3 drugs, pretty much any 3 drugs are better than 2 drugs. And so these are a whole host of different trials that have been done to show that. And I put up some of this information because what are you looking at when you're looking at this information? What are you trying to decipher as you're trying to help your doctor decide what's best for you? So one of the things you want to look at is how many other therapies were these patients on? Because a patient who's been on 5 different therapies, if you remember our curve about what disease history looks like in myeloma, are very different from patients who've been on 1 or 2 lines of therapy. So these are early relapse trials, meaning that these patients had 1 to 3 prior lines of therapy. So not patients who've been on 7 or 8 lines of therapy. And when we looked at these overall response rates for the 3 drugs versus the 2 drugs, we're seeing that they're all higher in the 70 to 80% range. And that means that 70 to 80% of patients who get these 3 drugs have a response to these drugs in treating their multiple myeloma. And then those curves, that median progression-free survival, how long before the cancer comes back? And that's what we see here. We're looking, at least for the first one, when we added daratumumab to bortezomib and dexamethasone, 16.9 months for patients who got all 3 drugs versus 7.1 months before the cancer came back for patients who just got bortezomib and dexamethasone. So this is the type of information that changed how we treat myeloma, and now we prefer triplets. So progression-free survival, how long before the cancer comes back? And then there's overall survival, which ultimately that's what we really want to know. But because our patients are living so much longer, because our drugs are so much better, the amount of time that patients are living with myeloma is so long that it's hard to wait for those trials to read out. So while we still care about the overall survival, we look at these, what we call surrogate endpoints: how long before the disease comes back, how many patients achieve MRD negativity, as a predictor for what the overall survival will look like, because it takes so long now for our patients to give us that information. So in these trials, you can see here patients who got the triplet versus the doublet, they were living, closer to 5 years versus just over 3 years. So this is another just looking at these triplets versus doublets and sort of hoping to establish that we know that these triplet therapies are better than these doublet therapies because of all the work that's been done. And this is true with our older drugs, with our newer drugs. And so that's sort of where we look in the earlier lines of therapy. And I've intentionally left out the discussion for the CAR T here because you're going to have a whole section on CAR T. So I didn't talk about CAR T in the early relapse because you will be hearing more about that. But then when we break our relapses into early lines of therapy and later lines of therapy, this is when we start looking at some of our novel therapies and our bispecifics. So for historical perspective here, I wanted to set the stage, so to speak. So we talked about some of our earlier relapses, patients in those trials where we looked and we saw that patients had seen 1 to 3 prior lines. Now we're looking, these were trials that were done, and the selinexor trial and the carfilzomib trial were in patients who were more heavily refractory. So these were trials that led to the FDA approval of some of these drugs. And we looked at patients who were very, very heavily pretreated. And we were seeing response rates of 23%, 39%, and that was good enough to get some of these drugs FDA approval. And we looked at how long these therapies lasted, and they lasted 4 months. And we thought, that's pretty good, and that's good enough. How long were these patients living? 8 to 12 months, and we thought that was pretty good. That has changed significantly with some of our novel therapies. And so I presented that as historical perspective because this is why we are so excited about where the field of myeloma has gone in the past several years, because we have fundamentally changed the natural history of this disease. Those graphs and those curves I showed you about how deep our remissions go has changed because we have better therapies. And as we learn better how to use them, we have changed the natural history of this disease. So the backbone for a lot of this is BCMA. So BCMA is a B cell maturation antigen. It's a protein expressed on the surface of certain white blood cells, B cells mainly, but it's particularly expressed and overexpressed in patients with multiple myeloma and expressed on their plasma cells. So it helps to regulate the survival of these cells. It's also a protein that gets chopped off the surface of the cells so it can circulate in the bloodstream, which is important for understanding over time how these drugs work, or if we can see if there are targets for who can optimally respond to these types of therapies. And so when we have discovered this B cell maturation antigen, some of our newest immunotherapies are solely targeted at how we get myeloma cells dead using this protein. And so there are 3 main ways that we are using this protein now in FDA-approved therapies and not quite so FDA-approved therapies to target these cells expressing BCMA. And so CAR T, and I'm just wanted to briefly touch on because you'll hear a lot more about it, but CAR T is essentially when we're sending off someone's own T cells to be trained to attack this BCMA protein on the surface of our plasma cells. BiTEs, it's a similar process in that we're activating T cells, but it happens inside the body. So it's the drug itself. It's not the drug that has taught our T cells how to attach to the BCMA. It is a drug that has 2 arms, and one arm is grabbing that BCMA protein on our cancer cells, and one arm is grabbing our T cell, because those T cells, as Joe has talked about, is part of that immune system that helps us control cancer. And when we grab the cell and the cancer cell and the T cell and shove them together, the T cells can activate and help our immune system to destroy BCMA. And that's how a BiTE works. So a BiTE is taking a little chunk from our cancer cells and taking our T cells and shoving together. The CAR T is when we send these cells off to school, and you'll hear more about that, but they're sent off to school and then released. And then the antibody drug conjugate, it's still more like an antibody in that it recognizes BCMA, it binds that protein, but now it's more like a Trojan horse, because here's the opportunity. So you bind that protein and it can help the immune system recognize, kind of like a monoclonal antibody, to help kill those cells, but it delivers a special drug into these BCMA expressing cells to kill it. And so that's how it works differently. It's still binding BCMA, but instead of binding it to activate the immune system in the BiTE or CAR T way, it's delivering the Trojan horse, the toxic drug. And so, to work here. So these are the CAR T trials. So these are, and you'll hear more about these. I just wanted to give an overview. These are where we initially saw the FDA approvals for these CAR T cells therapy, and that they were approved in later lines of therapy. So patients who had already seen other lines of therapy. So if we remember from our historical perspective, how well drugs work in this setting, we were excited when we could get 20 to 30% response rates. And here now with the 2 CAR Ts that are approved, we're seeing response rates of 50 to 98%. We'd never seen that before in this heavily pretreated patient population. How long is this lasting? With cilta-cel, we saw 34.9 months, almost 3 years. We didn't see that before. That's why these drugs have fundamentally changed the nature of multiple myeloma. So moving on more specifically to the BiTEs, setting that stage again. So the BiTEs are those cells where we've got 2 arms and we're grabbing BCMA or whatever our target is, and we're grabbing a T cell and getting things to work. So that BCMA x CD3, BCMA is expressed on the cancer cells, the plasma cells, and CD3 is a marker for T cells. So that's how it recognizes those T cells and grabs it. And so again, these therapies, so there's now 3 of them FDA approved. Teclistamab, elranatamab, and linvoseltamab was our newest drug that was most recently approved. So all of these drugs looked at patients who'd already been exposed to multiple therapies. Again, we were happy when we saw 20% response rates. And here we're seeing 60, 70% response rates. And then when you look at how long they're lasting, patients are living longer, patients are having responses that are more durable because these therapies are fundamentally different and working better. So with all of our therapies, we have risks of side effects, and the things that we look at most in these immunotherapies, the CAR Ts and the bispecifics, are the cytokine release syndrome or CRS and the neurotoxicity. So you will hear more about that. I just bring it up so that you don't think I'm ignoring it. It's not that all of our drugs are these wonderful miracle drugs with no side effects. And that's one of the challenges and why the patient-doctor conversations and communication is so important, because I can tell you how great a drug is and the side effects can make it not matter, or the perception of side effects can make it not the right choice for you. So these are, again, those progression-free survival curves that we talked about. And so when we look at these drugs that have been now FDA approved for the treatment of relapsed refractory multiple myeloma, what we're seeing here with these multiple, so for teclistamab, we're looking and we're seeing that these patients are doing well over time. And so you can see, how many patients are still responding after a period of time. But the separation of those curves, those 2 different curves, this is where the MRD status matters. So patients who are getting deeper levels of response. So this one was actually looking at complete responses. But when you see deeper levels of response, the drug works better for longer. And so we're seeing that in all of our new therapies, and because these are newer trials, this is some of the data that we have. So we can say that these drugs are working well, but then there are subpopulations of patients in whom it doesn't just work well, it works incredibly well. So with elranatamab, you can see there at 24 months, patients who've achieved very good deep responses, those patients, almost 90% of these patients still haven't relapsed over 2 years later when they're achieving those deep responses. So what we need to help and work on in the next frontier is there a way to predict which drug for which patient gets us these deep responses? Can I know ahead of time who that patient is going to be? And if not, how do I make them into that person to get the most out of these therapies? Because these therapies, as we see, can be incredibly effective. So again, like all of our drugs, there's these side effects. So hypogammaglobulinemia is something that we unfortunately had to learn a lot about during the COVID situation, because as all of these trials were going, COVID hit, and so we quickly found out that our myeloma patients are uniquely susceptible to infectious complications. And we knew that before, but it turns out that a lot of our immunotherapies and BCMA expressing cells are involved in our immune system and fighting infections. So hypogammaglobulinemia is really just when we're suppressing the ability of healthy plasma cells to make the antibodies that we need to help fight infections, we're more likely to get infections. And so over time, we've learned better how to prophylax and prevent those infectious complications. Cytokine release syndrome is when the immune system is activating to do its job. Most myeloma patients know at some point in their history that when you get sick, you can get very sick and have things like fevers and low blood pressure. And that's really the result of your immune system doing its job and helping to try and keep you safe. And with some of our immune therapies, we're getting the immune system to help fight our cancer, but our body doesn't necessarily know the difference between sickness from infection or sickness from the infection, which is our cancer. And that's when we see these cytokine release syndrome impacts. And then the neurotoxicity you'll hear more about, which is some of this, the other complications from some of our therapies, and you'll hear more about. And then the keratopathy is the bane of the existence of belantamab, and we'll look a little bit more at some of that data because that's where we're going to hear about it and part of what is going on with why it was not FDA approved. So we have our bites against BCMA, and then GPRC5D is another target that has become available in multiple myeloma and is actually quite interesting because this is something that we don't really know what it does. We just happen to notice that it's expressed highly on plasma cells. And so it's really expressed on these plasma cells, not a whole lot of other places. It doesn't need GPRC5D, so you can not have GPRC5D, still be perfectly fine, and still have multiple myeloma. But it just so happens that most multiple myelomas do express it. So that makes it a really great target for treating multiple myeloma, because when you look at what does a target mean to treat a cancer, you want it to be widely available and you want it to not be expressed on the other cells that you need. You know, for example, if a target is highly expressed on your heart, then it can lead to heart problems. So when you find a target that's highly expressed on your cancer, but not highly expressed on other cells, it can be a good target, which is what we see with GPRC5D. And the other thing with GPRC5D is it doesn't circulate in your bloodstream. So that can have implications for how long the therapy can last, because you can't cleave it off the surface. There's not a natural mechanism for that. So talquetamab is our GPRC5D approved therapy right now. This is another bispecific T-cell engager. So two arms now, we're not targeting BCMA, we're grabbing GPRC5D and the CD3 is the T-cell and working the same way. So this was, again, patients who had multiple prior lines of therapy. When we design a new drug, we have to figure out the best way to give it. And it turns out with talquetamab, it's probably every other week. And some of that has to do with how T cells work probably, but you can see here again, overall response rates are incredibly high, 70%, how long these therapies are working over a year for patients who were on the every other week dosing. So again, just highly effective. And again, this is just looking at how well this drug works in the different types of ways you can give it, whether you give it weekly or every other week. Side effects of GPRC5D expression can be really challenging. So it's not very widely expressed, but where it does tend to be expressed, it tends to be it causes taste changes, and they can be pretty profound taste changes almost immediately. Causes skin and nail effects that can be pretty significant. It can cause nail loss and challenges with using your hands because the skin gets so bad. It doesn't have the same infectious risk because it doesn't cause the same level of hypogammaglobulinemia because it's not targeting those other B cells. And it doesn't have overlapping toxicities with our BCMA agents, which probably has implications for us moving forward. And so just a quick touch base, someone had mentioned, belantamab, what happened. So this is that antibody drug conjugate. So it was developed years ago, FDA approved, or it had a conditional approval. and we were giving it to patients, and then it didn't meet the endpoint that they said, so it was taken off the market. It was still available, compassionate use, and then they came out with new data looking at belantamab in combination with other drugs. And so the DREAM 7 and the DREAM 8 trials were looking at a belantamab combination versus another triplet combination. And what it showed is that belantamab had greater impact and better improvements in outcome compared to the standard triplet, which was daratumumab, bortezomib, dexamethasone, or pomalidomide, bortezomib, and dexamethasone. So this was in patients who they were not as heavily pretreated, which is why you're seeing some of the durability here. But based on this data, we were all pretty excited and thought we were getting somewhere, but this was just recently not approved by the FDA. And one of the large reasons for that is because of the ocular toxicity. So you can see changes to vision with these drugs. And so those concerns have limited, where we are now, it's not FDA approved. So where this goes, we'll be following. We all expect that at some point they'll be able to make it viable and palatable, because all of us probably have anecdotal stories of patients who've been on, I have a patient who's been on belantamab for 6 years, compassionate use now, and hasn't relapsed. So there are, again, patients who get tremendous benefit from this. And as we're looking at all these T-cell engagers and T-cell exhaustion, another role for targeting this BCMA is probably important. So they're also, not immunotherapy. So cereblon inhibitors are still immune modulators, kind of involved in, similar to the proteasome inhibitors. Those are coming. Those are likely to be FDA approved soon. There are other therapies looking at bromodomain inhibitors and other ways of targeting myeloma cells, and those therapies are still in development. There are more BiTEs and CAR T cells coming. So looking at CAR T cells, not from your own T cells, but from someone else, looking at different targets. There's GPRC5D, CAR Ts in development, looking at not trying to grab the T cells, but maybe NK cells and using those cells to help kill the myeloma. FCRH5 is later in development, is probably going to be released. It will be FDA approved, hopefully at some point, which is another bispecific with a different target. And then as we have all these drugs, we have to learn best how to use them. So we're looking at them in new settings. Can we use these drugs in frontline settings? How does that change the natural history of the disease? Can we use them in combinations? What happens when you give teclistamab with daratumumab? What happens when you start using IMiDs after CAR Ts? All of this is being looked at. And then they're even looking at combining some of these things. Can we look at both BCMA and GPRC5D? So if we can do it with one drug here with one arm, what happens when we add another arm and do both things at the same time? And then not only are we best learning how to use the drugs that we have and how best to combine them, but how often do we need to dose them? What's the balance between toxicity and outcome? So putting it all together, clinical trials paved the way for these advances. And that's why I spent some time to go through how we look at some of that data, because not only as a patient can you be informed about this, but you can also help create that data and help us to know the best way to move forward. And so clinical trials is something that I always encourage people to ask about and understand. And that's often a way to get access to some of our best therapies ahead of time. There is no one strategy for relapsed multiple myeloma. And as we've heard, it has to be tailored to who you are, your disease, your goals, and your interests and motivations. But within that setting, triplets are better than doublets. Novel therapies are becoming game changers, and it has significantly changed and raised the bar. So now we're unlikely to come to the FDA with a drug that has a 20% response rate in the relapsed myeloma and get the same responses and the same approvals. We've raised the bar and we've fundamentally changed how we treat this disease and what it means to be an effective therapy in this disease. But we're still not done yet in changing the history of myeloma and using these drugs. We still have work to do in how best to use them. So ultimately, we have more drugs, which is more options, which is good for patients, but it's a greater responsibility for shared decision-making and helping to understand not just what the landscape of myeloma looks like, but how to create the roadmap for your life and your disease. So this is sort of all the things that I just said.
Wow, that was fantastic, Priya. I mean, so much to take in, but presented so clearly and so beautifully. So thank you very much for doing that. 35 questions have poured in while you were speaking. You actually addressed a couple of them, but please. A reminder to the audience, keep bringing those questions in. We are going to cover as many of them as possible. We're going to do a rapid fire question round towards the end of our session. But as Robin promised us at the start, it's time for a little break. So Robin, do you want to give people a break?
Absolutely. So I think it's time for everybody. We all know in the myeloma world, drinking water is important, stretching and moving is important. You've all been sitting, absorbing, listening, learning. So let's all take a little break, take a pause, stretch, come back, and we'll see you, let's say 10 minutes. So if you're on the East Coast, it's 7:10. We'll be back at 7:20. Thanks, everyone.
Well, welcome back, everybody. Hope you got a quick break, a little bit of hydration, maybe some heavy meat to go with the heavy information that we've been giving you. But this has just been a fantastic seminar so far. Really enjoyed Dr. Leip's presentation, and I know you're gonna love listening to Dr. Lynn, who is a remarkable physician at Mayo Clinic in Rochester, and she's dedicated so much of her life to CAR T-cell therapy. So we thought we would put her in the driver's seat to talk about putting you in the driver's seat of CAR T. So Yi, I will turn it to you, my good friend. Always good to have you with us.
Thank you so much. And it's certainly a pleasure to be here. And it's so nice to hear that overview of all the relapsed treatment options. And so now we can focus in a little bit more on CAR T because the logistics are so much more intense. And it's not exactly a treatment that today you can get at any oncology clinic. So as I tell all my patients, getting to CAR T is literally more than half of the success. Because CAR T only works when we actually can infuse it in patients. So we're delving into a little bit to make sure people can get onto the road and get to that road to remission, hopefully with CAR T therapy. So here are my disclosures. And so to carry that analogy, we'll think about, well, when do we get on that journey, get into that car for CAR T therapy, how to make sure we can get on there and stay on track and navigate that entire journey. So as what you've already seen, basically in different pictorial format, this is just another view of the lines of therapies as we think about for multiple myeloma and what the options are. And right now, there are 2 FDA-approved CAR T that are in the green box here, shown cilta-cel and ida-cel for short. They were both approved based on single-arm studies in the later line setting, 3 lines or later. So they were initially approved for patients who's had at least 4 prior lines of therapy. But in the recent year, we've seen the data from randomized control study in these earlier line settings. So potentially as early as after 1 line of therapy for cilta-cel and after 2 lines of therapy for ida-cel, compared to other conventional drug therapy options. And both of those CAR Ts performed better in terms of progression-free survival, and that's how we have the current FDA approval as we do. And you see here the bispecific antibody as well. In the approved format right now is still in that later line setting. And just very, very recently, we had Limbo that also joined that class. And so really not just the immunotherapy, but as we think about almost all the other treatment we have for myeloma, CAR T is the only one where the logistics of getting your cells collected to make into CAR T, getting that treatment, staying at the CAR T center for management of the immediate side effect, that is intense. That is logistically intense. But thereafter, that recovery period is the only treatment we have right now in myeloma where there is no maintenance treatment. There is no daratumumab, there's no lenalidomide, there is no regular dosing of any drugs. So for those patients who do well after CAR T, they can really focus on recovery, getting their life back to, I've had patients tell me, remembering finally what it's actually like, what their life is like before they were diagnosed with myeloma. So that is not a trivial benefit, to overlook. This is the package insert information on the 2 approved CAR T. What you'll notice here, a little bit technical in terms of how that CAR construct is designed. There are differences that likely contribute to the differences we see in terms of the timing of the side effects, some of the different incidences of how often the side effect occurs, and some of the differences in the response rate. In general, these are given with the same type of chemotherapy drugs. The goal of those chemotherapy drugs are really to help prepare the body, not so much to kill the myeloma cells, but reset the immune system a little bit. So when the CAR T cells are infused, they're in a better environment to recognize the myeloma cells, try to kill them, and sustain that desired myeloma killing activity. So generally, these chemotherapy drugs are given for 3 days, and then there's a 2-day rest, and then the CAR T cells are infused. And what you'll see here, there's a little bit different, dosing with the CAR T cells. And if you delve into the details with the clinical trials, people can say, the more CAR T cells you can get within the range, you might see a better response. For the manufacturing, they're going to try to make the best CAR T product that they can. And as long as it fit within this range for that patient, it would be what we call within FDA specification. It can be given as an approved product. But what that final dose is a number of factors. How fit is the patient's own immune cells coming into the manufacturing, which may be impacted by the recent exposure of treatment the patient might have had before the cells are collected, how much myeloma burden there are, and the impact on the immune system. There's a lot of variables we can't necessarily control. For the dose, the goal is always to make kind of the maximum within the range possible. But that's why also some of the logistics of getting to cell collection, getting to CAR T dosing can be important. So we have some data with how these CAR T cells are doing in the real world. And of course, with the follow-up we've had, the best comparison we have is really in the later line setting, because the approval in the earlier line are fairly recent. So we'll start to see some of these data coming into report with some of the upcoming conferences. So what I'm showing in the leftmost column is what's been reported with the very first clinical trial that led to the approval of ide-cel or Abecma, looking at, CRS, cytokine release syndrome, ICANS, immune cell associated neurologic syndrome. These are the immediate side effects that we generally think is happening in that first 2 weeks after CAR T infusion. And these are the side effects where the FDA mandates where you need to stay within the CAR T treatment center. So the team that knows how best to monitor for it and manage it can be there to take care of you through the treatment. So we keep a close eye on these immediate side effects, and we keep a close eye on the response. That's the last row. The overall response, of course, we like to see that deeper response, complete remission, stringent complete remission, and the median time of progression-free survival. Because we all know once any drug is approved, the patients who could be considered to receive it will be broader, will be more like the real world patients who may have the disease and not be restricted to the clinical trial where they may always try to pick the patient with the best kidney functions and the best heart functions and all of that. And, we know as we all age, not all of us can have the best of all these organ functions and status. Can we still safely potentially get these therapies? So it's encouraging to see with 2 different real world reports, the middle one being a number of CAR T treatment centers in the United States. These are the high volume CAR T centers. And the data on the right is the CIBMTR, or Center for International Bone Marrow Transplant and Cellular Registry. So that is more centers across the US and even beyond US. And so you'll see a bigger number with that report. But in general, if you look at that first row, about 3/4 of the patients who receive ide-cel in the real world would not have met clinical trial criteria for ide-cel. So it's encouraging to see now a number of these are either because of their disease status or other medical conditions. But despite that, overall, when you look at the rate of those patients who receive CAR T, the rate of them receiving, having any of these immediate side effects, or some of it what we call grade 3 or higher. So these are more severe side effects that needs to be managed, sometimes in the ICU, needing more level of care. So these you can see are very low rate, and they remain very low even in the real world population. And if you look at the response rate, overall, these are very comparable in terms of the percent of patients who are able to achieve that deeper remission and the average time that they would stay in remission. So that's very encouraging to see that a nice adoption or transition into real world practice. And similarly, when we look at cilta-cel or Carvykti, for myeloma. So CARTITUDE-1 was the first registration trial that led to its approval. And I'm showing the same type of immediate side effects and also the overall response rate and the median progression-free survival time. And again, in the real world practice, about more than half of those patients who received the commercial cilta-cel would not have met clinical trial criteria. However, the overall initial safety outcome and the response, again, are very comparable. So I hear this all the time. By the time patient has relapsed myeloma, they may have had stem cell transplant as part of their frontline or early line treatment. So for stem cell transplant, age limit is something that's talked about a lot. So it's quite often that when CAR T comes up, either the doctor or the patient may ask, is there an age cutoff? Would I be too old to get CAR T? So of course, as I mentioned, there's some immediate side effects where having strong heart function, lung function is important to be able to withstand those safely. But in general, we think the biologic age is not so important as the patient's overall fitness or resilience is another term that we would use. So, a patient who with every infection might end up being in the hospital, get quite sick, and takes many months to recover, may not be able to tolerate the side effects of the cytokine release syndrome as well as somebody who's much older, but is still very physically active, is, literally running marathons. That patient could probably tolerate a little bit more of that cytokine release syndrome. And so what you see here is the data from both registration trials for both CAR T, where patients up to the age of 78 were treated. And when they looked across age, there was no difference in terms of concern for the immediate side effect. And overall, the response were very comparable. Now, another thing that can be very common in patients with multiple myeloma for a variety of reasons is the kidney function may not be 100% already. And that's not something that's necessarily studied as much in clinical trials, especially since giving chemotherapy is also part of the CAR T treatment, and the chemotherapy drug sometimes needs to be adjusted or potentially omitted if the patient's kidney function is not perfect. And so in the real world consortium, they look at patients who then have less than perfect kidney functions. And, we're still learning how best to manage that, including patients potentially who might be on dialysis. So it's something that we're all learning together across the CAR T treatment centers. But it's encouraging to see with these early reports that at least for patients who don't necessarily have the perfect function, we would be able to safely administer CAR T, and some of the immediate side effects are not more severe. Blood count recovery overall in the long term is comparable. And looking at the response rate, the progression-free survival, it can be comparable. Now, it does take a very coordinated multidisciplinary team, including the kidney specialists and so on, to work together to really learn that. So for each patient, that is why that evaluation is very important to make sure, does this data potentially could apply to, that patient's specific situation. So we know now that CAR-T is approved up to potentially first relapse. So when should the patient potentially consider CAR-T? In general, as mentioned earlier, both by Joe and Bria, we're still learning about the best sequencing. We do know that, the more treatment somebody could have, they can get more beat up from their treatment, right? Not only the immune system, but overall fitness and so on. So in something like CAR-T that can be very intense, probably the earlier we think about it, it could be better for the patient to get through the treatment. Those T cells might be healthier. So it's always worth considering at the earliest possible opportunity CAR-T versus other options in that line of therapy. The patient journey, as I mentioned, is not so straightforward as the doctor prescribing it, getting insurance authorized, and coming back to the clinic to get this. There are a limited number of centers that are certified to get CAR-T. And so if you are not living near one of these centers, then your doctor may need to refer you to a CAR-T treatment center. And that referral timing logistic could be very important to make sure that we're really minimizing the time it takes to evaluation, clearing the insurance authorization to get the eligible patient to cell collection. Really shortening time that if your disease is progressing, the current treatment is not working, to get the CAR-T made so that the clock starts ticking to when you could potentially have a treatment that you can get. And once the CAR-T is collected, currently, both ide-cel and cilta-cel have on average a month to a month and a half of manufacturing time. So that's a time where both your primary hematologist at home and the CAR-T center needs to be very well coordinated to try to keep that myeloma disease under control, ideally to reduce the disease burden if possible. So then to make sure that you're still overall clinically doing well, feeling well, your disease is not getting out of control, so you can actually get to the CAR-T dosing when the CAR-T product is available. So that bridging management is very much an important part of getting to the CAR-T dose. And now we'll get into a little bit more details for when you come back to the CAR-T center, the CAR-T product is ready to infuse, and of course, staying at the CAR-T infusion center or treatment center for the immediate management. But once you're able to go home, it's not necessarily immediately everything is done. We're now learning with more and more patients who can get CAR-T, but what are the ongoing recovery looks like at the intermediate, that first few months to 6 months to long-term years range, and what are the survivorship needs with all of that. So we're really ensuring the overall quality of life once somebody's disease can be in remission. So this has come up a little bit, bridging to how we understand things today is important, because what we have seen both from this real world report for patients who get CAR-T who had prior exposure to same target immunotherapy or same target therapy, so BCMA therapy. A lot of these patients really had prior exposure to belantamab. Some of them did have exposure to bispecific antibody. So you can see that red curve. If there are prior exposure to that, the overall period of staying in response can be much shorter. And that's what we've seen also even in earlier lines of therapy in clinical trial setting for patients who may have had prior exposures to antibody drug conjugates. So that would be something like belantamab or bispecific antibody. If you take a look at that, median progression free period really drops significantly with that. Now, we're also learning, knowing all these tools could be at our disposal, and all of these tools are also being studied as early as frontline setting. Are there lengths of exposures, a period of what we call washout from the last time a therapy is used, would those things help reduce some of these impact so that it's not once you use something, you might completely remove the possibility of using something else. We don't necessarily have all these numbers all worked out. That is something that we're still learning. So as of today, we would say if the patient, or I would say in my clinic, if the patient was seen to be medically fit and could be considered for CAR T, and of course bispecific in that setting may be an option, I would say let's try CAR T first because of this information. And also after CAR T, the patient could have a period of not having any treatments, after which if myeloma does come back, one, there may be a lot more options with the number of therapies that are coming into practice. And then two is, using bispecific after CAR T, probably somewhat related to this period of recovery that we can see. We don't necessarily see as big an impact on the response to bispecific in that order of sequencing. So bispecific may still be more of an option after CAR T, but right now, CAR T, not so much immediately after a bispecific. Okay, so now we think about, well, how do I actually get to the referral centers, right? What are considerations that could be important? So that communication of your primary hematologist with the CAR T center is not just to really reduce all that time it takes to get to the CAR T collection, but some of that discussion to say, I'm thinking CAR T may be the next option. And if there are a few options for this current line of therapy, are there things we can pick that has less of a toxicity to the T cells, so we can keep that CAR T option, potentially get a little bit more fit T cells. And even if it's that connection is made just right at the time of referral, we really need to get to therapy now. What the patient is currently getting and planning to really stopping the drug as closely as possible to the washout period needed prior to collection to really avoid delay can be important. And then, of course, talking through that bridging management consideration. If the consideration to use CAR T is in those earlier lines, so first, after first relapse, second relapse, and so on, there are more drug regimen options that could be at their disposal that patient's myelomas haven't seen. So more likely switching to something different that could reduce the myeloma cell burden. In the later lines, therapies, it may be a little bit less of an option, right, of what you've seen so far in the treatment landscape. And we know that myeloma disease burden is going to be important. It can help that CAR T, we think about the simple maths, right? The more T cells there are and the less myeloma cells they have to kill, the more likely they can win the battle. So higher likely chance it could stay in remission, but also higher likely chance that there's less of that immediate reaction when the CAR T cell try to kill the myeloma cell. So less chance of getting to that very severe cytokine release syndrome or some of the intermediate side effects that we'll touch on. So this is data that was recently presented to say, well, for those patients who are really considering CAR T in those later lines, they've gone through some of these drug combinations that are available in the earlier lines. What are some other tools that could be at a disposal? So I just mentioned getting bispecific antibody right before CAR T cell collection, maybe not such a good idea. But that's in the context of using the bispecific antibody regularly as it is prescribed until the patient progresses. And so we think that long exposure, the T cells could be more exhausted by the time the myeloma progresses. But in this particular analysis, we're looking at patients who had most of these patients had their cells collected, and they're looking for options during bridging time, so while the CAR T cells are being made. So those T cells that are being made haven't necessarily been seeing the bispecific antibody. And so what we see in this setting is that because we're only giving this talquetamab in a very short time frame, until the CAR T cells are ready. And then most of these patients went on and received CAR T cells. So Overall, the side effects to talquetamab are somewhat more limited. Most of these patients are able to go on and get CAR T, and the overall response in that setting is actually quite encouraging. So again, lending clue to say we could potentially be using these in combinations or sequencing in a different way that could be more helpful rather than potentially not so synergistic or additive. So we kind of covered a lot of this half of the patient journey. And so if we can get to the point where the CAR T cells are ready and coming to the CAR T centers, really the FDA just recently changed a lot of the rules and regulations around the requirements for management and monitoring of CAR T. They used to require that patient need to stay at the CAR T center for 1 month. And that can be prohibitive for some patients to try to leave their home, find a caregiver who can come with them to stay at a different location for a whole month. And so now that we have a lot of knowledge about what patients go through, what the side effects look like, really for these, especially for these two particular CAR T products, a lot of the immediate side effects are likely to start in that first 2 weeks and then be over by 2 or 3 weeks. So now the FDA doesn't mandate that all patients have to stay at the CAR T center for the whole month. They could potentially go home as early as 2 weeks. And so I'll say with the caveat, presuming, for that individual patient, if there's nothing else that would require additional care, and that the primary hematology clinic at home can take care of the other things, because you're not necessarily 100% recovered at 2 weeks, but these CAR T specific side effects are likely mostly resolved. And so the rest of that recovery in that second half of the month commonly is getting your appetite back, catching up on your hydration, getting your energy back, watching for blood counts for recovery, and keeping a very close eye for monitoring for any potential infections that could develop. So cytokine release syndrome, unlike when I explain to patients, unlike the chemotherapy where when you get side effects from the chemotherapy drug, that's the effect of the chemotherapy drug on the healthy cells in the body, not necessarily on the cancer cells. So we don't necessarily know if the chemotherapy drug is working. When patients experience cytokine release syndrome, that is very much a good sign that the CAR T cells are seeing its target, are seeing those myeloma cells and acting. And the symptoms are very different. It's like when you have a bad flu or pneumonia, because it's a similar type of immune reaction, right? In an infection, your immune system is trying to get rid of the infection, and you have fever. You can start with fever. You start to feel achy all over. You start to not have appetite. These are exactly the early onset cytokine release syndrome. In this case, because the CAR T cells are genetically engineered to kill myeloma cells, what we're watching for is for this to not go into overdrive and have this, what we call hyperinflammation, where it can really stress out your heart, your lungs, the kidneys, the organ system. So we're watching this. A little bit of CRS is good, but in general, we're really tempering that down pretty early because we're recognizing that it is not absolutely required for those CAR T cells to get rid of all the myeloma cells and achieving the remission. So it's good when we see it, but sometimes patients worry because we warned them so much about cytokine release syndrome and they're anticipating this, and we say, well, it's not absolutely required. You don't need to get so sick that you're going to the ICU. A little bit of fever is good, but we can temper this down so you're not suffering through all the other side effects. Currently, the FDA-approved treatment, initial treatment, is a cytokine blockade called tocilizumab. It can work very fast, within hours after it's given, faster than steroid, actually, although steroid is second-line treatment. And we're pretty much deciding when to let some reaction happen versus tempering it, really based on the patient's overall picture of the symptoms and also their overall medical condition coming in. We're not necessarily treating based on any specific labs. In terms of the neurotoxicity, now ICANS or immune cell-associated neurologic symptom is talked about a lot. You'll see that reported in all the clinical trials. But if you notice the numbers I showed from the clinical trial and the real-world experience at first, it's not that high. The rate is not very high, and the severe rate is even lower, way less than 10%. In general, these overlaps with cytokine release syndrome. So if you were to have a very bad fever, it were to keep going on, then you might get some of these more confusion, not finding the right words, not being able to communicate. But if we're really managing the cytokine release syndrome, we wouldn't see the more severe manifestations of those neurologic symptoms. Now, I did see there were some questions in the chat already. So the ones particularly for myeloma CAR T that we have seen coming out of clinical trial, we're still seeing in real world practice, certainly probably on a lot of patients' mind, are some of these intermediate onset. The cytokine release syndrome is done. Any neurologic ICANS is resolved. But towards the end of month 1, generally through month 6, more commonly kind of in that first 3 months, there may be some specific neurologic symptoms that may happen. So on average, we think about 10% of the time, we may see this cranial nerve palsy. And that could be manifestation very similar to Bell's palsies, if you've heard of that. So the nerves that innervate parts of the face, if that gets inflamed, it can happen on one side or two sides, then you may not be able to close your eyes as well or move your mouth. And these sometimes can be mistaken as potential stroke symptoms. But really, these are, for the most part, limited, and they do respond to IVIG and steroid treatment. The ones that are probably more alarming to people is the Parkinsonism. And when this first showed up in patients who were getting this in later lines in the clinical trial, it was up to about 4 or 5% of the patients who were treated. Now, with some of the strategy in terms of reducing the myeloma disease burden coming in, it may be lower. It might be closer to a couple percent, but we're not able to completely get rid of this. And this can be alarming because the symptoms are very much like what you may have heard for Parkinson's disease. So patients may not communicate normally. They may not be able to get movement started, harder time getting up from chairs. Their gait, their walking patterns becomes abnormal. And this is potentially patients have died from these symptoms or from attempts to treat this, which sometimes involve very high dose chemotherapy to get rid of CAR T cells. So right now, what we really tell patients is watching for these signs and symptoms. These are times that they have gone home. And at the earliest time that there's any concern, to contact the CAR T center. Because we're learning all the time across all the centers, what are people trying, what may seem to be effective. And so what we know today may be even different from 3 months or 6 months from now. Currently, what we think is, if we find this at the earliest symptom, there may be some treatment that can help reduce the severity or the course and potentially resolve this. But if we wait until the patient may have the full spectrum of Parkinsonism, that becomes much more difficult to manage. We're also trying different interventions earlier on in the CAR T course to see if we can reduce the incidence of this further or the severity, but these are still very much under study, and so we'll learn more about those in the coming years. And I'll just touch on Guillain-Barré syndrome. Again, it's very rare. It's a black box label, but I would put that probably at less than 1% of the time. But just to be aware, if you is otherwise recovering well and suddenly develop very severe back pain, that may be an early sign, and get in touch with the CAR T treatment center and start some of the evaluation for that. Another not so common side effect that are now becoming more apparent in this time frame, kind of later part of month 1 through month 6, most commonly in that 3 months window, is this enterocolitis, really bad diarrhea. These are diarrhea where you can't leave the house. You need to be hospitalized to get nutrition, to get electrolyte replacement. So we've tried to survey this again across some of the top CAR T centers in the country. Not very common. We think maybe 2 to 4% of the time. However, because the manifestation can be very severe, very important to be reconnected with the CAR T center, who also work with GI specialists to really look across, rule out any infection that needs to be managed. There are biologics that can be used to make this, to help resolve these symptoms, but most importantly, also to rule out more rare complications like T-cell lymphoma that can occasionally be seen with this. Now, more commonly, what people may be dealing with, I'm done with my CAR T infusion, I've recovered my cytokine release syndrome and so on. Most people are not necessarily going to get these scary side effects that I've been just telling you about. But more commonly, that blood count recovery may not happen completely by month 1. It's possible that as we use CAR T earlier and earlier in line of therapy, we'll see better recovery. But in the later setting, it may take up to 3 months for the blood count to completely recover. Well, get close enough to normal where you don't need frequent monitoring or transfusion support. So it's important during that time frame, rule out any nutritional causes, rule out any infections, make sure there's no recurrent inflammation that could be driving all of this. And then only if the blood count don't recover beyond month 3 to consider bone marrow evaluation to look for other causes. And as long as things like secondary cancers are ruled out, interventions like stem cell boost have been found to be helpful, although before that, some of the growth factor support and so on can be tried. And why is that important to keep in mind? Because this is the largest study that we have to date. Now, this is not just multiple myeloma, but over 5,000 patients who've received CAR T for myeloma, lymphoma, leukemias in clinical trials and in FDA-approved therapy setting. Across all of these patients, so the half of the circle, the blue part of the circle, half of the causes of death not related to disease relapse is infection. So supporting patients through blood count recovery is really important. Monitoring for potential infections and ensuring there's good prophylaxis against infection is very, very important. So the IMWG has published guidelines. There's also other societies with guidelines in terms of antibiotic considerations, IVIGs, and so on. And so these are things we need to partner with, right? The CAR T centers may be familiar with some of these, but working with having a good handoff with the primary hematology clinic to make sure that these things are being followed through for the first year, sometimes 2 years or more post-CAR T period. So in summary, these are some of the practical things. I hope you can walk away from my talk tonight, how to get to CAR T, right? So first, that discussion is very important because there's so many things that are individualized, right? Overall, what's the risk for your myeloma? How has it responded to prior treatment? How is your medical condition? Some of these side effects, you may consider them very differently depending on where you are in your life, in your family situation. If you are now getting onto that road to CAR T therapy, having a caregiver in that first month or potentially first few months to support you through that treatment and recovery period is very important. It's good that the FDA has shortened the time for requirement to stay with CAR T center based on how these CAR T products behave. But just know that, you're not back to 100% exactly at 2 weeks. And so there are some different risks to look for in that first month, first 3 months, 6 months, and things to consider as you continue on that journey to recovery. Here are some other safety things that are still here. So FDA used to say you cannot drive for 8 weeks after CAR T infusion because of some of these potential risks for neurologic side effects. And that can be very, lifestyle restricting for people. So fortunately now that's also reduced for that first 2 weeks. But just recognize, for that small percent of patients who may get some of these later neurotoxicities, that may not be safe. So, with a caveat. And then finally, as we're still learning, as we treat more and more patients, how to manage for some of these less common but potentially severe side effects, staying in touch with the CAR T Center because we may have better ways to either mitigate that or manage that. So thank you very much for your attention, and I will hand this back to Joe and Robin.
Okay, wow, that was absolutely amazing. I think what we've heard, I'm so glad we had a break in between because the amount of good information and the tips and just learning not only about myeloma and CAR T, but I thought it was really interesting to see 5,000 people and to see how well it's working across many different types of disease states, including myeloma, of course. So at this point in time, it's really wonderful that I have the opportunity to introduce Becca Liu. She is with MD Anderson Cancer Center. She is a big part of the IMF's Nurse Leadership Board, and now she's going to get into some practical information about living well with myeloma, managing side effects, and having good conversations with your healthcare team. So, Becca, I'd love to turn this over to you, please.
Thanks so much for that wonderful introduction. Thank you guys all for being here tonight. Tonight, we're going to talk about living well with myeloma, no matter where you are on your journey. The IMF's Nurse Leadership Board put together these slides to help you feel informed and empowered as you live with myeloma. I'm really excited to walk through them with you. Let's see if this works. Okay, so living with myeloma can feel like going through different seasons. First, we're going to start with winter, and this is where we're going to learn about treatment options if the disease comes back. Then we'll move into spring and we'll focus on managing side effects and staying strong. And next is summer, where we will celebrate our successes and the progress we've made. And finally, we arrive at fall. And this is when we can enjoy life's bounty and the moments that matter most. Each season has its challenges and joys, and you don't have to walk through them alone. So first, we're going to start in winter, and this is where we're going to discuss treatment options at relapse. So this slide is a very helpful way to picture the journey with myeloma. Many people start with conditions like MGUS or smoldering, and these are precursor states that Dr. Joe discussed earlier. Later, when the myeloma becomes more and more active, we start treatment, and this helps to reduce the disease and keep our patients in remission. But over time, we see that the disease will come back, and we start to use new treatments to bring the disease under control again. And what we know is over time, this myeloma can get harder and harder to treat. And one reason for this is something called clonal evolution, meaning that the myeloma cells change and they start to adapt, making them a lot tougher to fight, right? So at first, one type of myeloma cell, as depicted in the picture here, is red. That might be the main problem, right? We treat it, we knock out red cell population, then another type of cell might start to rise, and that would be like the orange cells, right? And those start to grow, and we give them another therapy, we knock them down, and then another cell starts to become more powerful, like the blue. And this is what happens with each relapse, and that's why each relapse brings us new challenges. The good news, myeloma treatment has come a long way, as we've all heard tonight. And today we have many treatment options, right? Researchers continue to discover new drugs and better ways to combine and sequence the ones we already have. And clinical trials are really helpful in understanding how to attack myeloma from different angles. This gives us more tools to help you live well and for longer. Okay. So Dr. Lin did a really great presentation on CAR T, so I'll kind of overview this really quick. But this treatment involves taking your T cells, re-engineering them to target specific protein markers on the myeloma cell. We manufacture them, and then we put them back in your body so that they can directly attack the myeloma. And how it works, again, is, you have to, what's important is to start talking to your care team early about whether CAR T might be an option for you down the line, so you're on that team's radar. If you're approved, the T cells are sent off for manufacturing, which takes about 4 to 6 weeks. And during this time, you might receive something called bridging therapy. And this is to keep the disease under control while you wait. Usually this therapy is stopped within 2 weeks, 2 weeks before the CAR T infusion. Once the CAR T cells are ready, you're going to receive them during infusion, and you might spend some time in the hospital. And this is really where we need our care partners to help during that treatment and recovery process. After treatment, your team is going to monitor you closely for side effects, including that cytokine release syndrome and the neurological effects that could happen, like ICANS. And additionally, the clinical team will support managing low blood count and administering transfusions as needed. During the recovery period, it's important to avoid driving, as Dr. Lee mentioned, for at least 8 weeks, just to give yourself enough time to heal. Right now, we have 2 FDA CAR T cell therapies. ID-cell is approved for patients with 2 or more lines, and cilta-cel is approved for patients with just one prior line of therapy. For CAR T therapy, it's very important that patients are in fairly good health with good organ function and can handle the chemotherapy that we're giving. One of the main side effects of this treatment is infections, right? And again, I want to emphasize again, tonight's keyword is caregivers, how important our care partners are during this process. Care partners are there to help with travel, they're there for emotional support and even everyday needs. But they're also very important in noticing any changes to your thinking or behavior that might signal a side effect, like neurological issues. And once we know that, we can start addressing them early. Another exciting treatment option is bispecific antibodies, which we've already heard about tonight. And the great thing about these treatments are they're off the shelf. And they're available after 4 lines of therapy and have really great response rates. Bispecifics can also carry risks like cytokine release syndromes and neurological side effects, very similar to CAR T, but usually they happen in lower grades. These drugs typically have step-up doses before hitting that target dose. And at some institutions, these step-up doses might be administered in the inpatient setting for closer monitoring. So currently we have teclistamab, we have elranatamab, and now very recently we have linvoseltamab that was approved. These all target BCMA, which is that special marker on the myeloma cell. Talquetamab targets GPRC5D, is also another bispecific on market right now. These are highly effective treatments that add to our growing toolkit in fighting myeloma. So choosing the right treatment for myeloma involves looking at lots of different factors. And some of these factors include how long did the last treatment work, how aggressive the disease is, and your overall health. We want to consider what treatments you've tolerated in the past, whether you prefer oral regimens, IV regimens, subcutaneous regimens, and the cost of therapy. At the end of the day, the decision is yours and your care teams that you make collaboratively together. We want to know your goals, your concerns, and what matters most to you. And that really helps to drive the treatment decisions in that conversation. So again, your voice matters in these decisions. Before your appointment, it helps to write down questions like the pros and cons of each treatment option. And this is really helpful in just kind of like organizing your thoughts. Let your care team know that you want to actively participate in the decision-making process. And don't hesitate to ask for more time if you need it. There's a lot to process, and if you need more time to think about what your goals are and your values, then take that for yourself, right? But make sure your care team knows what those goals and priorities are. This is your journey, and your priorities should help guide our plan. Okay, so now let's spring into how we can manage side effects together. So a major risk is infection. Preventing infections are critical for people living with myeloma. Infections remain the leading cause of complications. So some simple steps you can take are like maintaining good personal hygiene, such as, practicing hand washing. We want to avoid large crowds, people who are sick, and this means, no buffets, no crowded concerts, things like that. And make sure to keep up with your immunizations based on your healthcare team's recommendations. Finally, you'll want to follow your team's recommendations for supportive medications, which we'll talk in these further slides. So again, CAR T and bispecifics really can increase that risk for infection. So there are many preventative measures that must be taken to protect you. First of all, you're going to want to be on antiviral medications like acyclovir or valacyclovir, and this prevents shingles, which are very common prophylactic treatments that are a part of most of our myeloma therapies. Bacterial infections can happen, especially in situations where patients have lower neutrophil counts, and this is a huge risk in CAR T bispecific therapies. To protect you from that, your provider may prescribe antibiotics like levofloxacin as needed, especially if your white blood cells counts are low. There is a greater risk for opportunistic infections like pneumocystic Jirovecki pneumonia. So medications like pentamidine or Bactrim to prevent this sort of pneumonia may be administered to you, especially if you're getting CAR T therapy. Antifungal medications may be prescribed based on your risk. We usually like to give drugs like posaconazole for high risk, and then fluconazole for lower risk. Antivirals for COVID, flu might be prescribed if you need it. And very importantly, ensuring that you all have good IgG levels is very important to preventing infection. So IVIG infusions are given if immunoglobulin G levels are low. We usually treat IgG levels under 400, or if you have frequent infections. And finally, if your white blood cell counts drop, your neutrophil counts drop, we might use growth factors to help you recover those counts. And we might also prescribe you some of these antiviral, antibacterial, antifungal drugs to ensure that you don't actually become infected. Okay, this slide covers cytokine release syndrome, which we've heard a lot about tonight. And again, this occurs when there's bulk T cell activation that leads to a massive release of inflammatory proteins called cytokines. And you get this constellation of symptoms that you see here, fever being the most common sign. CRS typically shows up 1 to 5 days after treatment, often mild, but can become serious. And that's why we want to monitor them closely and treat the symptoms quickly. This slide talks about neurotoxicity, which can happen with or without CRS and can also be equally very serious. These symptoms include, headache, confusion, sleepiness, tremor, seizures, hallucinations, balance issues, things like that. Again, care partners play a huge role here. They know you best and can spot subtle changes, helping us act quickly if something is off. I've had family members tell me that their loved ones were acting kind of weird, kind of strange, and they just weren't sure. And we go ahead and do some urgent evaluation, get the necessary imaging, and lo and behold, the patient is starting to have some neurotoxicity that we are able to catch pretty quickly. So some treatments like talquetamab can cause unpleasant side effects like dry mouth, taste changes, and difficulty swallowing. And this is because the treatment targets a unique cell markers called GPRC5D that exists in some of our other cells. With dry mouth, we advise our patients to frequently use mouth rinses, gels, sprays, and to avoid things like hot beverages. With these symptoms, patients may complain of taste changes. And while there isn't a slam dunk cure for this yet, there are some things that we can try, like dexamethasone oral solutions that you can, swish and spit. And then there's also zinc supplementations that we suggest to our patients to try. Patients can also try things like sour candies before and after meals as well. Taking small bites of food and sips of water is helpful if you're having difficulty swallowing, but definitely talk to your team, especially if you are losing weight and having trouble eating. Sometimes you might need to be referred to a nutritionist for extra support. And finally, seeing your dentist regularly and having those regular dental cleanings and evaluations are helpful. We want to make sure that we're checking for any jaw issues, oral cancers, and any cavities that might be present. So many of these symptoms can feel very distressing. So, education, learning more about it, and emotional support are the key. Talquetamab, the joys of talquetamab don't end there. They can also cause skin and nail side effects, and often patients will complain of skin rashes like palmar and plantar desquamation, which is essentially the peeling of the hands and feet, which you can see here on this patient's foot. Supportive care, though, can manage this pretty effectively, like, using lotions like Vanicream, heavy emollients. In some cases, topical steroids might be needed in addition to antihistamines. Nail changes can also occur, and you can see that this patient here has nails that are kind of torn and rather thin. Patients are encouraged to use nail strengtheners and heavy moisturizers to help with this. And I know these look very, very concerning and they look a little scary, but usually these side effects are mild and they do improve with time. What we see is, these things self-resolve just given some time. The best friends for these type of things are moisturizers like Vanicream, topical steroids, antihistamines, and using nail strengtheners. GI symptoms like diarrhea or constipation can occur as a result of these treatments. Diarrhea can happen due to antibiotics or other therapies that we give. And if there's no infection, this can be managed with antidiarrheal medications at the instruction of your provider. It's helpful to avoid things that might stimulate diarrhea, like caffeine, carbonation, sugary drinks, things like that. Constipation can also happen with pain medication and all the treatments that we give you. So it's very important to protect your gut, eat a balanced diet full of fiber, stay hydrated, use fiber supplements if recommended. And if you're having further issues, let your team know so that they can help. There's lots of different things that they can try when conventional therapies haven't worked. Pain is a very common symptom in myeloma, and whether from bone disease, neuropathy, or procedures, managing it effectively is key to keeping you feeling like a spring chicken. So since myeloma is a cancer of the bone strengthening therapies are very important in helping to prevent fractures. Myeloma can cause your immune system to not work as well. And so, using those prophylactic medications that we discussed is also very important. And, especially drugs like antivirals for preventing shingles. But pain management isn't just about medication, right? There's different things that can help manage pain, like complementary therapies, especially for things like neuropathy. Acupuncture has been found to be effective. And I'm a big believer in acupuncture. It really works. So speaking of peripheral neuropathy, this occurs when there is damage to the nerves on the extremity, and this can be a result of the disease or from the medications we give, such as bortezomib. Symptoms of this can include numbness, tingling, burning, pain in the hands and feet, or sensitivity to touch, or even muscle weakness. It is really, really important to tell your team if you have these symptoms so they can adjust the treatment or add some supportive medications to help manage that pain. Some things that you could try, though, include massaging the area with cocoa butter regularly and taking neuroprotective supplements like B-complex vitamins, drinking green tea, things like that. But neuropathy can affect the way we feel. And so make sure that the environment you are in is safe from things like tripping hazards that could, that you might, injure yourself with. Again, it's very important to report symptoms of peripheral neuropathy. Unaddressed neuropathy can lead to permanent nerve damage, and we definitely don't want that, right? Okay, we have a love-hate relationship with steroids because they cause so many side effects, but are still so integral in myeloma therapy because it can enhance the effectiveness of our therapies. Steroids are very important in myeloma treatment. They can bring side effects like mood swings, sleep problems, weight gain, hair loss, increased blood sugar. There are things that we can do to help manage these side effects, like taking steroids at the same time each day with food, using over-the-counter medications to ease some of the side effects, like your, proton pump inhibitors. Discuss these things. Discuss your love-hate relationship with steroids to your healthcare provider, and it might be appropriate for them to actually adjust your steroid dose if the symptoms are severe enough. Okay, healthy kidneys are vital, and this is especially so for myeloma patients, especially because myeloma can affect the kidneys along with other chronic conditions. The medications that we give you can affect how your kidneys function, so staying hydrated is one of the best ways to protect them. Most of us don't drink enough water, but we hammer your kidneys with all sorts of medications and treatments, so it's even more important for you all to stay hydrated more than the average person. Fatigue is the most commonly reported symptom in myeloma, and it comes from a variety of places, right? It comes from the disease, the treatments we give, the procedures you undergo. One of the best ways, though, to fight fatigue is to stay active, even though it may feel counterintuitive. Most importantly, if fatigue is affecting your quality of life, Let your team know. It may signal something else like anxiety or depression, which are very common and it's manageable. But those things do need to be addressed. And now we are in our summer of success. Care partners are essential in the myeloma journey, and having the strong social ties has been shown to improve outcomes and quality of life, increasing longevity and overall satisfaction. Whether it's a family member, friend, or support group, your care partners are part of your care team. This is a critical and often understated part of the treatment. Don't face your cancer alone. Give people in your community a chance to care for you. And I have to remind my patients of this, especially the ones that are always like, oh, I'm okay. There's nothing wrong. It's all good. No, have people help you. And as we enter fall, it is important to remember that living well with myeloma also means caring for your overall health. It's easy to get caught up just focusing on this disease, but there are definitely other health risks that are equally important to manage and to reduce the risk of. Staying connected with your primary care provider and keeping up with routine screenings help manage other health risks. We've talked a lot about collaboration, and your myeloma team can work together with your primary care providers to maximize your health and wellness. Healthy habits like eating a balanced diet, maintaining good sleep hygiene, those are all essential for wellness with or without myeloma. And finally, I want to highlight the many resources the IMF offers. There's a wealth of information available to help you stay informed and supported. I know Dr. Joe mentioned this earlier, but one of my favorite tools is IMF's AI assistant, Milo, which answers your questions anytime you need. Remember, you're not on this journey alone. Milo is there too. Thank you so much for joining me today, and I'm here for any questions you have as you continue to live well with myeloma.
Thank you, Becca. This was such good information. Every single piece of it I was so interested in, and especially hearing more about different things that maybe every patient and care partner don't think about. Like you mentioned, acupuncture as a resource. And so if people aren't thinking about that, that's maybe something to bring up and how it may be helpful to them. And also to all my care partners out there, my heart is with all of you. So, please, number one, take care of yourself, right? So you can be your best and then take care of your loved ones. But now we're going to transition into what we're going to be kind of summing it up. And I'm going to throw it back to Dr. Joe.
Great. Thanks so much, Robin. It would be remiss of us to have a whole session on relapsed therapies, although every speaker has in some part mentioned it, to not at least just spend a couple of minutes on clinical trials. And I think what we'll do is I'm just going to make a few comments about clinical trials and see if our panelists have any other things to say specifically about it. And then we're going to dive into the questions because we have about 60 questions. I know we won't be able to get through all of them, but we're going to do kind of a rapid fire round with all of our speakers. And I think in the last half hour, we can cover just about all of those questions. So a few things about clinical trials, and I know there are a couple of questions there that will relate to it as well. But we gave it the title Demystifying, and we say that only because sometimes clinical trials can be a little bit mythical almost to patients. They feel like it's this thing out there that I don't really fully understand, or very honestly, it can be something that offends people when they hear about the history of what's happened with clinical trials in this country and other places. It's very natural for particularly certain populations like the African American population, for us to feel that clinical trials are really not appropriate and have been misused and abused in the past. So a few things, just some general comments, and I'm not even going to use slides because you've seen so many slides tonight. We're just going to keep it simple. But I think a few things I'd like everybody to remember. Number one, the reason why you would go on a clinical trial is for you. Yes, you are contributing to the greater knowledge. Yes, it may help myeloma patients and other patients down the line. But really, it's okay to be selfish about this. The idea is for you to participate in something that can help you, that is going to give you at minimum the standard of care, but very often give you early access to treatments that are either not yet approved or not yet approved in a certain combination. The clinical trial world is so competitive. We want to make sure we're providing options for patients that can really benefit them. Which leads me to point number 2, which is you're not going to be given substandard care on a clinical trial. You're not being given a placebo saying, oh, well, let's just treat your myeloma with nothing, right? No, we give people treatment for active myeloma. And we have to, in comparator trials, at least, where there's 2 arms comparing, both Dr. Leip and Lynn showed many studies that were comparisons of 2 different treatments. We have to, at minimum, give the standard of care. Very often it's the standard of compared to something new or compared to something added to the standard of care. Thirdly, you have the right to be skeptical. I am not going to hide the history of what's happened in clinical trials in this country. And it has led to massive reforms, to all sorts of regulations, but it has to be built on trust with the team that you're working with. We've shown repeatedly that when you develop a strong trust and therapeutic relationship with your healthcare team, with amazing doctors like Doctors Lynn and Leip, with amazing nurses like Becca, when that relationship is built, it actually improves your outcomes, not just your quality of life, not just the touchy-feely, this is good, we feel good, we go into clinic, and I'm a hugger with a lot of my patients. My patients, often like to hug me or I them, and that's a wonderful part of it, but we've actually shown that relationship improves outcomes. And so it is important to have trust, and it's on us as a medical community to build that trust. It's also on the patient to want to have that trust with their team. One of the things, for example, we created at the IMF this last year was something called the Diversity in Clinical Trials Academy. And we have 6 individuals, 5 patients and 1 care partner from underrepresented communities who themselves have been on a clinical trial, and they share their stories at our patient meetings. Whether on video or in person, they talk of what it's like to be on a clinical trial. And it's fascinating to listen to many of these individuals speak and say, when I first started a clinical trial, I covered my ears. Like, I didn't want to hear about it, and yet many of them will attest to the fact that they're with us today because of a clinical trial. And so it's one thing to hear about a trial from Dr. Joe or Dr. Lynn or Dr. Leip or Dr. Lou. We want you to also hear it from individuals who are with you. And then lastly, and this may come up in one of the questions, but the other thing I want to share with everyone is that we are trying very hard at the IMF for people to have greater access to clinical trials. And this is in multiple ways, multiple programs, but also even just pragmatically, as some of you may know, we have developed a partnership with a group called Spark Cures. And it's all at our myeloma website. If you go to myeloma.org, and you can look at it different ways, it's /Spark Cures, or even if you go to the clinical trials section, they basically have developed a highly sophisticated practical search engine to look for clinical trials. If I type into clinicaltrials.gov right now, multiple myeloma, I'm going to get about 4,000 results. That's not going to be very helpful for me. But with Spark Cures, they can narrow it down to you can do this anonymously or with information based on how many lines of therapy you've had. What are you looking for? Do you want to stay in a certain geographical area? All of those things can be captured, and it will tell you in real time what trials are available to you. And of course, as Robin mentioned from the start, we're always happy to hear from you on the info line as well, and we can help guide you through that process. So before we dive into Q&A, I just want to turn to each of our speakers and see if there's anything that was sort of burning in their hearts about clinical trials that they want to add to what I've just shared with us. Maybe I'll start with you, Yi. Is there anything, because you have led and do so many clinical trials, is there anything from your perspective that you would like to add about trials?
No, I think, it's always a discussion, right, with the patients. And usually the way I think about clinical trials very much, if it's early enough in line of therapies where we know the outcome with the conventional treatment, then we really want to show what the potential advantage to the patient. We can't guarantee, but there needs to be a strong rationale. But some of these that's really very new, first in human, just coming out, where we don't quite yet know how the later, very much it's in the condition that's not just, hypothetical for the next patient. I think, that is all.
Well, thanks, C. I know that you cut off a little bit there at one point, but that's fine. I think we got the essence of what you're saying, and let me just reiterate it and emphasize it a little bit that, you made a very good point that we want to have a strong rationale for a study. We can't always know, we can't predict. That's why we have to do trials. We can't know in advance until we do it if it's going to be of benefit. And there are times when we do trials where we're testing brand new agents in phase 1 trials where we don't know that benefit yet. But it speaks to the real importance of that conversation. That's what you started with, right? The importance of the discussion with the patient. People can't get informed consent unless they're informed. It's really on that basis. So thank you so much for that comment. Maybe I'll turn to Becca. Anything else, Becca, from your perspective that you see is particularly important and valuable as we talk about clinical trials?
Yeah, I echo everything you said. I think trials are so important. And without clinical trials, we wouldn't have had, as many therapies as we do now. I remember when I started, like even 10 years ago, there was only a few drugs. And after that, many of my patients were like, what's the next trial? What's the next trial to help prolong their lives? And, without the support, especially from our, minority populations, we don't have the data to find the effective regimens. And the one other thing I'll add about trials is I help to actually run trials at my site. And I think patients would really like to know that your trial team is watching you very, very closely. Like my patients have my cell phone number, they are texting me, and, not because it's really because I need to know what is going on in their healthcare, right, in real time. And I find that a lot of our patients appreciate that kind of, specialized, customized care. And I do think that, across the board, trial teams are very, conscientious and diligent. Yeah.
Thank you so much. Absolutely. And it is so important people know how carefully they are watched on trial. Well, Bree, I'll give you the last word on trials before we do the rapid fire question and answer period. Any other thoughts? I know you've run so many trials over the years.
Yeah, one of the things that I would say is that a lot of times clinical trials are done at some of the larger centers just because we have the patient volume and the capacity, but that doesn't mean that you can't get insights and information from wherever you are. So I find that I often partner with some of my community providers and am in touch with them about their trials, because it's not just, it helps to know who is appropriate for referring into me for trials and what trials I have available. But it's also helpful for a patient because, as you mentioned, Joe, trust is so critically important. And when you don't necessarily know me, sometimes enlisting the help of the provider who's known them the longest can really help facilitate a trusting relationship when patients are referred to me. And on the same token, just because I have a lot of clinical trials doesn't mean I have every clinical trial. So I do the same thing for my patients. So just because I might not have a clinical trial for you at my institution that I think is the best for you, I will A, be honest about that, but B, I can help you navigate things like the Spark Cures. And you can bring that to me and say, hey, well, what do you think about this trial? And I'm happy to give you my honest opinion and help reach out to those physicians at those other institutions if that's the case. So I think that in summary, what I'm trying to say is that deciding on clinical trials is something between you and a particular provider, but involving your entire care team throughout the entire process of your journey can be critically important and a useful tool both for access and for understanding and making decisions about what's right for you.
Beautifully said. Thank you, Bree. I agree 100%. Not only that, you answered one of the questions, which was, do doctors ever refer patients to clinical trials outside of their own center? And the answer, of course, is yes. I mean, we want the best for our patients. We tend to know our own trials the best, but now more than ever, because of things like Spark Cures and our partnership with them, we can know more of what's available in the area that someone is in. And sometimes some of these trials can allow people to travel even further distances. All right, Robin, I am ready for rapid fire. I'm ready to do this. We've answered some of these questions as we've gone, so I'm going to take a little liberty. Let me start with this one question I'll answer quickly. What are the signs that you are relapsing? This is just such an important question. I want to make sure we reiterate it. Typically, the first, if you will, sign of relapse is you don't feel anything at all. It's that we see it in the blood work. Dr. Leip showed to us that monoclonal protein, whether you're an M spike, whether you're a light chain in the serum or in the urine, that typically starts to rise before we feel anything. Typically thereafter, we might see some changes in blood work, like a drop in the hemoglobin or something of that nature. And then we may get, unfortunately, the signs and symptoms, the pain, the fatigue, unfortunately, a broken bone or kidney damage. But that's why we watch the disease so closely in the biochemical realm, so that we can catch it early. And this relates yet to one other question I got to quickly answer that we were actually submitted right before we started our session today, which was a patient who spoke about the fact that he's had myeloma for 19 years, had a long remission, and had no measurable disease. And then all of a sudden there's this tiny little M spike. And do they need to immediately treat it right away? And so this is where we go back to the discussion with patients. The fact that there is a tiny amount of disease, and we're going to come to an MRD question later that I'm going to get Bria to answer because she was the MRD queen there in her explanations, if someone goes from MRD negative to MRD positive, that doesn't necessarily mean that the whole disease is flaring and it immediately needs to be treated. In some contexts, we may consider that, especially in high-risk disease, but that's where the discussion needs to be had with the provider, because myeloma is multiple. There are some forms of myeloma that are extremely slow growing that we're willing to wait and watch for periods of time. I have a patient I saw in clinic today who's had a tiny little M spike that reappeared, and it's been sitting there for 1.5 years, and we've done nothing. And I've given her my favorite therapy, as I call it, nada, nothing, and she's doing well on it. And so we want to balance that with having to intervene. I know you covered this, Yi, already, but I'm going to ask you this question because it is so important. It keeps coming up. Can you just quickly summarize again, what is the latest about Parkinson's in the post-CAR T realm? Which CAR T does it happen with? How frequently does it happen? And how do we try to avoid it or manage it?
Absolutely.
Yep.
To go over today the latest information, and this is, of course, evolving every month. So what we call IEC or CAR T associated Parkinsonism has been seen with both CAR T product for myeloma. In fact, it has rarely been seen with cilta-cel or Carvykti, where it's more rare with ide-cel. Abecma. So, in cilta-cel, we think it could be anywhere 2 to 5% risk. Again, based on the myeloma disease burden coming in earlier line versus later line, we think, T-cell fitness may play a role. So in general, what we're trying to do is upfront, what can we do to reduce the risk? This is where, if at the earliest sign, right, that biochemical progression before you have very high end protein, lots of myeloma cells in the bone marrow. So just a little bit of protein that they're seeing no other symptoms. If we can get the patient to treatment in that lower disease burden rather than higher disease burden state, we think the risk is lower because that cilta-cel Carvykti CAR T is not going to react as much and then kind of kick off that downstream inflammatory response. That's the biggest or the most commonly used strategy where we see from CARTITUDE-1 to CARTITUDE-4, where more of that be more rigorously implemented, and we see that reduction of that 5% risk to maybe even closer to 1% in the clinical trial setting. In the real world, of course, as I show with some of the data, it's broader patients, right, coming in. Sometimes they don't have other options, so we think CAR T may still be the best option. And, you may not be able to reduce the disease burden to get them to CAR T dosing. So just knowing that there's a higher risk going in. Now, what many centers are trying is what we're seeing is, of course, disease burden is one thing that drives this, but cilta-cel Carvykti CAR T tends to have that higher level of CAR T expansion. And so we can see that even in that, particularly in that second week, which is typically when the CAR T expand after it's infused. And we don't necessarily need to measure the CAR T. We can see on a simple blood count was differential. We can see the lymphocyte number, and that's generally going to be reflective of CAR T presence at that time. So many of us are trying to say, well, if we see kind of above average expansion, maybe we don't need all that CAR T really for the remission. And can we try to reduce it briefly in that time period to reduce the risk? Now, this is just being tested right now. And so I think we'll have more data to know if that's helpful. This is also now being used in the trials for cilta-cel as well. And then, of course, beyond that is watching very, very closely. It's for that earliest symptom, which sometimes may be tricky. It's not, definitive. Is this really real? How long do we wait? And what we usually tell patients is we don't mind being we much rather sort through that and say, oh, maybe it's not, but to wait too long. And, because sometimes it's not the full set of symptoms. It could be any one of the symptoms. And sometimes that spouse or that family member is the first to notice that conversation is just a little off. That person's just not interacting the same way. And we would much rather to be contacted early at that point because in that earlier window, I think many of us have reported different case series experience with either trying IVIG steroid, sometimes injecting chemotherapy drug into the spinal fluid, sometimes giving bigger dose of chemotherapy. The key is if that inflammation is brewing, shutting it down in that window may help. But if we wait until the patient has full symptoms, then it's just more side effects from the treatment, and it may not be able to reverse all of those symptoms.
Wow, what a fantastic summary of a very complicated area. So thank you again. This comes up so often. I'm really glad you're able to reiterate it. Here's a question I'll try to answer quickly. What was the reasoning behind the ODAC decision advice to the FDA to reject Blenrep as a treatment for relapsed myeloma? Is it surprising given recent approvals in Europe and Canada? What are the next steps? And this is complicated, but the FDA plays a very important role in safety, and there was a concern about how this drug affects the eyes, and they felt that it was pretty clear in the discussion that the dosing had not been ideally set up. And even though the drug was very effective, that this was something that needed to be looked at further. It is a little bit surprising in some ways because the response with belantamab was so good. Was very impressive. And I think most of us, Dr. Light mentioned that she has a patient. Actually, one of my patients spoke at the ODAC that day because she's been responding so well for it for so long. But there are next steps. It's not over. The FDA has pushed back its decision about belantamab until October. A lot of discussion and review of other data will be had until then. And we do hope it will ultimately still be a choice for our patients. All right, here's a question. Research for increased better responses to CAR T for those with high-risk myeloma. Maybe I'll ask you again, sorry to call on you again, but one last, just quick answer here if you can. What is our latest thinking about CAR T for high-risk myeloma?
So there are some engineering of the CAR construct that may help in terms of seeing the response in high risk. There are some combination strategies to think maybe CAR T get us part of the way, but high risk, could relapse early, and with some of the other drug tools. So can we sequence them in a way to maintain that remission? I would say that's the shortest answer, but honestly, there's more trials coming and novel strategies. But these are some of the trials available today.
Excellent. What is the difference between relapse and refractory? So basically, relapse means someone's been treated, they've gone into remission for a period of time, and then at least 60 days has passed before their disease wakes up again. Refractory means someone's disease wakes up either while on or within 60 days of being on treatment. Becca, maybe I'll call on you in this one. If plasma cells grow out of control when the immune system is weakened, what are the best ways to strengthen the immune system? Now, of course, this is a loaded question, and there's a lot that can be said here, but maybe you could just comment really quickly on the importance of our immune systems and maintaining general health.
Yeah, so again, when our patients are at high risk for infection, so the general things that we can do, like hand hygiene, avoiding crowds, making sure that we are taking those prophylactic therapies that are prescribed by our healthcare team, our healthcare providers, things that will help prevent viral infections, making sure that you are seeing your team in follow-up to make sure that they're checking your blood work to make sure that your blood counts are adequate, that you don't need anything to support your white blood cells like growth factors. And finally, the other thing I can think of is making sure that your immunoglobulin G is sufficient, because we do know that when they are low, you are more at risk for infections. And replacing it's an easy way to kind of boost up your immunity.
Excellent. Yeah, it's so important because so many people will, oh, I saw this commercial for an immune booster, I must take it. And we have to be very careful. Myeloma is a cancer of the immune system. You might be boosting the wrong part of the immune system. So please take those with caution. A question here says, would you please say a few words about preventative protocols? We would love to prevent myeloma. So I look at this in two ways. One, there are some studies ongoing. We've profiled here before, for example, Dr. Urvi Shah out of Memorial Sloan Kettering with the Nutrivention study that is looking at a dietary intervention to potentially slow, if not stop, the progression to active myeloma. There's also all of the work and the study that we're trying to do to capture myeloma early enough to intervene to prevent active myeloma. Even very recently, the large Aquila study that treated high-risk smoldering myeloma, in a sense, is like a preventative study, trying to prevent people from developing active myeloma later. So let me tell you, this is a huge area of work and research. All right, Brea, I've got a question for you here that relates to MRD. I'll try to summarize it quickly. The patient says, my last 2 bone marrow biopsies showed my initial myeloma clone had essentially gone to 0, but there was a second clone that started to show up at 2,000 cells per million, and then on the second biopsy showed up, it increased to 2,600, while the original clone was still less than 3. I've never really been MRD negative. Should I be concerned that my myeloma is relapsing? I'm on Len and Dara maintenance and have had several years since my stem cell transplant in 2021.
So with MRD detection, they look for different clonal sequences on the initial biopsy sample. And then each time they check again, they probe for those sequences. And so it's not uncommon that, over time, myeloma, you can see different clones emerge that may have been there initially, or you can see, clonal evolution is something that we also see in multiple myeloma. So things can change over time as well. And so, from the very beginning, it's a clonally heterogeneous population that increases over time. So that is not uncommon that different clones emerge. And as our technology becomes better, we're better able to detect that. We don't have the ability at this time to say, well, this clone would respond better to this, or this clone would respond better to that. That's just not technology that we have. There are a lot of patients who never become MRD negative. And even amongst that patient population, there are patients who do really well. So MRD negativity is a surrogate marker that we have for how well someone will do over time. But there are still a lot of patients who never achieve MRD negativity who do just well as also. And so we just don't have the technology to understand or predict the path for those patients who don't achieve MRD negativity. So it's something that we can try to achieve. Some patients never achieve it, but if you've been doing, well for a long time after your transplant, I think that already is telling us that you're doing at least relatively well. And when to pull the trigger on, treating a relapse, I think that depends on how you're doing, how you're responding to the therapy, and what your goals are for, the duration of your illness.
Yeah, that beautifully said. So, I mean, so taking from what you've said, that it's not surprising that there's a different clone. The emergence of another clone doesn't necessarily need immediate therapy. And sometimes we see these numbers. I was talking to a patient today who got frightened by a number on the MRD negativity or positivity, that we have to be careful to put that in context. That actually, I get a match to question 25 when someone says, can you comment on patients who are MRD positive but have an MGUS-like phenotype, and I know this is a complicated area and I don't want to spend too much time on it because we want to answer some other questions, but I said it at the big MRD conference earlier this year in Miami, the sheer presence of MRD doesn't necessarily mean it's a very bad situation. What we need to determine is the remaining MRD Rambo or Bambi? Right? And sometimes it's just Bambi and it doesn't need to be intervened. There are some patients that, if you will, go back to a little bit of MGUS. It's for some reason we've shown. That's why I showed that picture of equilibrium. Sometimes, believe it or not, a tiny little bit of myeloma sits there and doesn't grow. And we don't necessarily always want to feel that we need to treat to get rid of myeloma to its bitter end. So there are some people who are like that in that situation. Okay, lots of great questions, but I'm going to speed through, and we've answered several of them right there. Maybe for you, Becca, the oncologist I saw told me not to swim in the ocean because of disease he might get there. I was a competitive surfer. I followed his advice. After so many years, I've lost my ocean mojo. Well said. Can I go back into the sea? What if, am I immunocompromised because of teclistamab? I mean, I know you're not right next to an ocean there at MD Anderson, so maybe I should be asking someone closer to the ocean, like Bria up northeast. But just general comments about this, if you could.
Yeah, what I tell my patients, this is my perspective. I mean, you have to live your life, right? And if this is like the thing that define your life, right? I think it's okay to do some of these things under, certain conditions. If the first month or so of teclistamab, usually we want to avoid we want to be extra careful with our immune system, right? Especially as, you have higher risk for, the infection and those type of things. But if you've been on it for, a good while, definitely talk to your team about this and see if it's okay. If your, white blood counts are robust, if things are kind of stabilized, I don't see why not you can't take a dip in the ocean, right? Just, careful of other ocean-related risks.
I think you've summarized it well. I mean, I think just in general, right? Patients, especially after COVID, have just been so afraid of infections, and you have to be comfortable with your decision. You have to talk to your doctor about it. But I try to tell my patients, you are not a walking, bubble boy, as it were, in the old movie. You are not so at risk of infection that everything you do is going to give you infection. You have to balance your quality of life with those risks. Yes, we take all the precautions, but I was just talking to a patient today about how they really want to fly to go visit their grandchildren. And I think it was important for them to do that. That's part of their life. And so there is a delicate balance. The caveat I always give is we learned even through COVID, the time when someone is at greatest risk of infection is when their disease is most active. So that fits with what you said, Becca, about that first month or so of the teclistamab. When someone is relapsing, or if someone's immediately after their transplant or CAR T, those are the times when people are at the highest risk, where we take the greatest precaution, if we can. All right. Bria, maybe I'll ask you this one. When Revlimid was used as a first-line treatment and has been stopped while someone was in remission, if there is a relapse, can that patient go back to Revlimid?
Well, sometimes, yeah. So, I mean, either when the Revlimid was stopped or if the Revlimid was at a lower dose. So in general, we consider that everyone's a little bit different in terms of what they define as refractory disease. But if you've been off of a drug, for me, I like a year. Some people say 6 months. But if you've been off of a drug for a period of time, probably the longer you've been off of it, the more likely you are to respond to it when you go back to it. But if someone has been off of it for 6 months to a year, it's likely to have residual activity.
Excellent. A newly diagnosed friend met with a national leader in myeloma. She told her that now people live on an average of 16 years before relapse. I'm thinking she may have misunderstood him. Well, not entirely, actually. We have a large clinical trial that is still undergoing, the Perseus trial that led to the approval of giving the 4-drug combination of Darzalex, Velcade, Revlimid, and dexamethasone together up front with a transplant, with maintenance, Darzalex and Revlimid for at least 2 years of the two, and then on to Revlimid, generally speaking. And there was a mathematical prediction that patients on that, on average, are not going to relapse until, depending how we looked at it, 12 or even up to 16 years later. So I think that's the most optimistic way to look at it. But the fact that we're talking about double-digit periods of time in remission is remarkable in myeloma. And so I think things are improving. All other things being equal, if a patient achieved MRD negativity just from induction therapy, stem cells were harvested, shared decision-making resulted in a watch and wait. Eventually, the patient was no longer MRD negative. Should they go to transplant or CAR T? If you get to this question, I would be interested in the opinion of each of the doctors. Well, thank you for whoever graciously asked the question. Maybe I'll just give it to one of the doctors, though. I will give it to Dr. Lin. So you have this person who's MRD negative. They decided to collect stem cells and wait. Now they're relapsing. What do you think? Are you going to go to transplant or are you going to go to CAR T?
Yeah, I don't think there's going to be one right answer because we have decades of experience with stem cell transplant, even in that early, right? That's kind of second line setting, if you will. We do know, so I think we need to take into consideration for that patient, what's the myeloma risk features, how long that patient, had response to that first line, how well the patient tolerated the treatment, what is the situation with the patient, are they, still working, main breadwinner for the family, taking all of those right logistics into consideration. It's not unreasonable, for some patient to consider a stem cell transplant in the second line setting. I would say, of course, seeing the data with CAR T, especially one-off, potentially no maintenance. It's approved without maintenance. We know the outcome. It's even CARTITUDE-1. We'll see the more mature data with CARTITUDE-4. Even in a later setting, a third of the patient in remission more than 5 years out. That's very tempting, right? And people are like, what if I can do that at this point? Why wouldn't I consider that? And I find sometimes when patients are thinking in that second line setting, they haven't gone through a lot of other treatments. Even though we say, well, the risk of Parkinsonism is maybe only 2 to 5%, and enterocolitis only 2 to 4%. We can mitigate the risk. We can't guarantee a zero. Sometimes for some patients, that benefit versus risk isn't quite right for their situation. So I'll just say not quite 100% clear cut.
Oh, that's a fantastic answer, though. You've outlined the data and the approach. Very helpful. I know our time is almost gone. Robin, I'm going to turn it back to you in 1 minute. But in the last minute, I'm going to answer a couple of quick questions. Very quick one for Bria. My wife is scheduled to begin Tecvayli line of treatment very soon. Since Linozyvic has now received FDA approval, does it have a higher response rate? Is it better tolerated, require less hospitalization? I know it's a tough question, but do you see a big difference between the 3 BCMA related bispecifics that you mentioned in your talk?
So there is a difference in the construct. So linvoseltamab is fully human, and it's the CAR T construct itself. And one thing to remember is in these clinical trials, they have not been compared head-to-head. So we have no data that looks at how elranatamab compares to teclistamab or to linvoseltamab. So we don't have that data in a controlled and randomized setting, and we probably never will. That being said, what we can see is that, the mechanism of administration is different. So linvoseltamab is IV versus sub-Q. Just because it's FDA approved doesn't mean it's always available wherever you are. It takes some time to get that, into an institution. All of that being said, the response rates for linvoseltamab look amazing. The durability of the drug looks amazing. It's still a BCMA target, so I think that it is a reasonable option. That's why it was FDA approved. It looks good. Is it better than the other ones? We probably will never have that clear data.
Yeah, I think you've said it very well. These are all great drugs. I think your wife is going to be well cared for with the treatment that she is going to receive. So, Robin, I wish I could get to more of these questions, but remind everybody that we keep these all. I try to answer them. I'll be doing a studio recording in a few weeks from now where we'll do our very best. And I'll turn it back to you because several questions came in saying, can we watch this again? Can we get the slides? I'll launch that back to you to close us off, Robin. Thanks again, everybody, for your great answers.
Sure. Thank you, Dr. Joe, and everyone here. It's one of the things that people want more of. We hear all this information so fast, but we need to do the replay and rewind and copy that slide. So the good news is the replay will be available along with the slides. I really feel like, back in the day, I used to tell people, print out the slides in black and white so you could write your notes on them and, bring them, with you to your doctor's offices and to your support group meetings. So the replay will be available exactly where we had told you earlier. So if you're on myeloma.org, you click on the publications and videos link there and you drop down to IMF videos. That's where they all live. And you can click right in there and find that. And Dr. Joe, I thought it was so interesting. You talked about our friend Dr. Urvi Shah and Nutrivention, which reminded me of the really great Living Well webinar she did for us. That, of course, that's still available on the IMF website as a replay. So everyone, please go back and check what all the different topics are and speakers. And, sometimes one topic resonates with you more than another. And we can all only learn what we need to know now, but always with an ear open to the future, right? And so think about that as you go back, listen to these replays, and what's most relevant and important to you at this moment in time. So again, I'm just going to give a last reminder for everyone that we hope you enjoyed this evening's program. Your information about your survey is so important to us. Dr. Joe knows we pour through these evaluations and then continue to hopefully make every program better. And we'll close tonight thanking all of our sponsors. Again, this night is AbbVie, Amgen, GSK, Johnson & Johnson, Karyopharm, Pfizer, Sanofi, and Takeda. And I would be remiss if I didn't thank each and every person that is on this webinar tonight. Thank you for being on for a long webinar. And, we hope that you found this valuable, and for each of the speakers tonight, Dr. Joe, Dr. Leip, Dr. Lynn, and Becca, you all have made a difference for the better in people's lives tonight and every day that you give us time in the myeloma community. So Dr. Joe, I'll give it back to you for the final wrap up.
You wrapped it up beautifully. Just to thank you to you as well, Robin, as being the hostess with the mostest, always being willing and able to help us through this. And please do reach out to us. I apologize we couldn't get to more of the questions, but I'll answer as many of them as we humanly can at an upcoming Facebook Live and time together. So thanks again, everybody, for joining us. Have a great rest of your night or day, wherever it is that you're listening to the replay. And please do connect with us at the IMF.